Indramayu, Mr. Rianto, Escap Nurse MCAP, the Honorable Director, Boromarajonani College of Nursing, Saraburi, Thailand, the honorable speakers, and also the audience and webinar participants. Let's say thanks to God who has been giving us blessing and mercy so that we can gather in this event without any difficulties. Amen. Ladies and gentlemen, here, I am Rani Fitriani as the Master of Ceremony. Will guide this International Webinar 2025 with theme Comprehensive Responses to Non-Communicable Disease, the role of multidisciplinary collaboration in prevention and care. Before starting our agenda, let me explain the agenda schedule of this webinar. First agenda is opening. Second agenda is the explanation from our speakers. And the last agenda is closing. All blessed audiences, the first agenda is opening. Let's start this agenda by saying Basmalah together. Bismillahirrahmanirrahim. The next agenda and the main agenda, which we are waiting for, explanation from our speakers, lecture from Indonesian and Thailand. The next agenda will be guided by Nurse Sophie Octaviani, PhD. And now, I invite the Nurse Sophie Octaviani, PhD. Screen and time is yours.
Thank you very much of the Master Ceremony for giving the opportunity to serve as the moderator for today's discussion. Can you hear my voice? Sorry. The Master of Ceremony. Can you hear my voice?
Yes.
So thank you very much for giving me the opportunity to serve as the moderator for today's discussion in section 3. Good morning for all the participants. Welcome to session 3 of the International Webinar with the theme Comprehensive Response to the Non-Communicable Disease, the role of multidisciplinary collaboration, prevention, and care. In this session, we will focus on a specific topic presented by the expertise of hypertension from Japan, with the title Hypertension in Indonesia, Research, Finding, and Trend. High blood pressure or hypertension has become a major global health issue, especially in the lower middle income countries. In the past 30 years, the number of people aged 30 until 79 who are affected by the high blood pressure has doubled from 648 million to 1.28 billion, with the most cases occurring in lower middle income countries, including Indonesia. Effective strategies for preventing and controlling hypertension are urgently required, especially in the research-limited setting. So, すみません。水谷先生、聞きますか？水谷先生、can you hear me? Yeah. Welcome to the seminar, Sensei. Can we start the seminar now?
Yes, thank you.
Hi.
So, may I start? May I start the presentation?
Wait a minute. Without further ado, my pleasure to introduce our invited speaker for today's session, the Associate Professor Mizutani Sensei, who are currently working as a lecturer in the Department of Integrated Health Science, Nagoya University, Graduate School of Medicine. She conducts many studies about hypertension in Indonesia, and we hope that this session will be informative, interactive, and helpful for all participants in understanding about hypertension in Indonesia. Mrs. Mayumi Mizutani, you have 45 minutes for presentations and 10 minutes for Q&A section. The time is yours.
Okay, thank you very much, Sophie Sensei, for the introduction. Let me share my slide. Okay, let me start my presentation. So I would like to make a presentation about hypertension in Indonesia, so research findings and trend. And thank you very much for inviting me to this wonderful seminar. So my name is Mayumi Mizutani. I'm an associate professor for public health nursing at Nagoya University in Japan. So look at this photo. So foto ini seperti Indramayu. So tapi ini bukan Indramayu. So foto ini kampung saya. So saya asalnya dari kampung. So ada banyak sawah dan petani. So ini nenek saya. So kakek dan nenek saya adalah petani. So karena Indramayu juga ada banyak sawah dan terkenal tentang produksi beras. So waktu saya datang ke Indramayu pertama, saya pikir, oh wow, ini seperti kampung saya. So saya senang melakukan penelitian di Indramayu. So I have experience as a nurse and a public health nurse. So I have worked in Japan, Uganda, and Indonesia. So in Japan, I worked in the neurosurgery department of a hospital. So I met many patients with hypertension and stroke. And in Uganda, I encountered many women with preeclampsia. And in Indonesia, I encountered many patients with hypertension and stroke. So through these experiences, I thought prevention is better than cure, and I focus on hypertension prevention and health promotion. So this photo marks the beginning of our collaboration. So we began conducting joint research in December 2013. So while I was studying in graduate school, there is a senior student from Indonesia. So she studied in Japan to receive a PhD, and her hometown is Indramayu. So that is why I started to come to Indramayu. And she's our supervisor who connected me and the Indonesian student. And with the support from Bapak Turmin and faculty members of Stikes Indramayu, I started to conduct research in Indonesia. So look at this photo. So after graduating from the graduate school, I became a docent, assistant professor, then currently associate professor. And fortunately, Ibu Sophie Sensei came to my university, Mie University in Japan to study at graduate school. And I was a supervisor at that time. So luckily, I have been able to continue research in Indonesia. So this is today's contents. So first of all, I would like to mention about the background of hypertension in Indonesia. Then I would like to introduce 3 researches that I have conducted. Research 1 is about health needs assessment in the district of West Java for health promotion. And research 2 is about positive deviance, frequent blood pressure monitoring among non-hypertensive middle-aged women in rural Indonesia. And research 3 is about community health volunteer support for regular blood pressure monitoring in Indonesia using spatial regression models. And finally, I would like to mention about lessons learned from research in Indonesia. So first of all, I would like to talk about the background of hypertension in Indonesia. So in the worldwide, there are 1.28 billion adults aged 30 to 79 have raised blood pressure, so which is doubling over the past 30 years. So the definition of raised blood pressure is, as you know, systolic blood pressure greater than 140 or diastolic blood pressure greater than 90. And please look up this map. So this is a prevalence of raised blood pressure among adults aged 30 to 79. And red color indicate higher prevalence. So the global average is 26% and 28% for males and 24% for females. And in Japan, it is like 23%, so which is a bit lower than the global average. However, in Indonesia, it is like 38%, which is higher than the global average. So hypertension prevention and control are urgent priorities in Indonesia. And Indonesian Ministry of Health recommend people to practice 6 healthy behaviors for non-communicable disease prevention. So that is these 6 behaviors. Cek kesehatan secara berkala, regular health checkup, and menyiapkan asap rokok, no smoking, rajin aktivitas physical activity, diet seimbang, balanced diet, istirahat cukup, enough rest, and kelola stress management. So these are the 6 health behaviors recommended by Indonesian Ministry of Health to prevent non-communicable diseases, including hypertension. So this graph shows the hypertension prevalence in Indonesia, according to the Indonesian Ministry of Health. So the left one shows the percentage of people who diagnosed as a hypertension by a doctor or using a medicine of antihypertensive. So that is 8.8%. The right one is about the hypertension prevalence by a blood pressure measurement. So even if they have a diagnosis, if their blood pressure was taken, it was high. So that is 34%. So what can we infer from this difference? So 8.8% for diagnosis and 34% if they are measured. So I think there may be people with undiagnosed potentially high blood pressure. So perhaps this may be they may lack opportunities for blood pressure measurement. So this slide shows the importance of community-based blood pressure monitoring from the current research evidence. Some systematic reviews emphasize the importance of home and primary health care in blood pressure management. However, in low and middle income countries, many with raised blood pressure remain undiagnosed. So in these 44 countries, 73% have ever had their blood pressure measured. So undiagnosed and uncontrolled hypertension elevate mobility and mortality and healthcare costs and reduce productivity. So this is a health system in Indonesia, as you know. So it is similar to our health system. So they have health bureaus and health centers organized by administrative district. So at the national level, they have a Ministry of Health, and provincial level, you have a provincial health office, and district level, you have a district or city health office, and sub-district level, you have a health center, and at the village level, health post is managed by the health center staff. So the difference is that Japan's health center focus mainly on prevention and health promotion, so not treatment. But in Indonesia, health center combines the function of prevention and also curative care. And so in the health post, the nurses from the health center go to the village, and nurses and community health volunteers collaborated, provide monthly blood pressure checkups. I think this is a very good system in Indonesia to prevent and control blood pressure, hypertension. So next, I would like to introduce about research one. So this is about health needs assessment for health promotion in an Indonesian district of West Java, that is Indramayu. So the purpose is to describe and assess the health needs in Indramayu as perceived by selected health professionals in the district. This is in order to explore a strategy for strengthening community health and nursing of the district for health promotion. So regarding the method, we used a case study design, and data regarding health needs of the district were collected through interview and also documents. which is guided by the precede and proceed model. And 7 participants from the district health office, district hospital, nursing school, and health center participated in the interview. And document on the website of the Indonesian Ministry of Health and West Java Provincial Health Office and Indramayu District Office were corrected. And this is a result. So distinct health needs were derived from multiple aspects. So they mentioned they have a remaining needs of maternal and child health and low access to sanitation. But in addition to that, they mentioned the problem is increasing non-communicable diseases like hypertension. And also they mentioned they have a limited human resources for health promotion and limited health sector budget. So this study concludes that local governments should address these complicated health needs in order to promote health of people. And I thought, so with these limited resources, so what are the possible solutions for preventing and managing hypertension, especially in rural area in Indonesia? At that time, I met the opportunity to know about the concept of positive deviance. So in 2016, there was an international conference which was held in Copenhagen, the capital city of Denmark. And I met the pioneering and leading researcher on positive deviance. So her name is Dr. Monique Stanning. So she's an associate professor for Tufts University from the United States. So I gained the opportunity to learn about the positive deviance. So this is a slide about the positive deviance. The premise of positive deviance is, in every community, there are certain individuals whose uncommon behaviors and strategies enable them to find better solutions while having access to the same resources and facing similar or worse challenges. And the positive deviance approach is asset-based problem-solving and community-driven approach that enables the community to discover these successful behaviors and strategies and to develop a plan of action. So this approach focuses on solutions in the community, and the community-driven approach and focus on asset, not the problem. So this approach can be applied even in limited resource settings because the solutions are within the community and does not need additional resources. So please look at this illustration and which actions is a positive deviance behavior. You see, everyone is trying to push this stone to up to the slope, and only this one is conducting a successful behavior. So without any big labor, he tried to roll the stone into the up to the slope. So in a positive deviance, so even with limited resource or difficulties, so there exist individuals who find better solutions. So this positive deviance approach focuses on locally available resources and encourage community members themselves to discover successful actions and strategies and promotes that solutions. So this is a famous example about using a positive deviance. So this is an example about solving childhood malnutrition in Vietnam. So this is a story of that Dr. Monique Stanning. So and also her husband about their work in 1990s to improve the child nutrition in Vietnam. And at that time, there were many children. So 65% of children under age 5 were malnourished. So the government, Vietnam government, asked that Dr. Monique Stanning and her husband to find a sustainable local solution and show results within 6 months, so within a limited time. So they tried to find how to solve the childhood malnutrition in Vietnam, and they conducted a study with this question. So why some children, even in poor households, were better nourished than others? So what they discovered in poor household was an action anyone in the community could do, yet most people were not doing. And this was the answer. So in that family who have a better nourished children, they added tiny shrimp from paddy fields, and they added greens of sweet potato plants. So most of them are farmers, so they have this kind of food, but most of them discarded. But for the positive deviance families, utilize these resources. So this food is rich in protein and minerals and micronutrients. So that's why those families will have nourished children. And in addition to that, because they are farmers, so they usually work from morning to evening. So they usually eat meals twice a day. So in the morning, and then they go to the field, and then after they work, they will take meals in the evening. So usually they take meals twice a day. But in those positive deviance families, caregivers feed the children 3 or 4 times a day, so many times. And they also actively feed the children, so not only waiting the children to eat, but the caregivers actively feed the children. So from this result, they developed and implemented a nutrition program, and then malnutrition decreased by 85% in the communities. So no special resources were needed, but just a local wisdom and practice prevented malnutrition in Vietnam. So next is about research too. So because I learned about the concept of positive deviance, so I thought how I can utilize this positive deviance into hypertension prevention and management in Indonesia. So as a background, in Indonesia, so hypertension is a significant health issue, and community health nurses need to identify those with early onset of hypertension by promoting frequent blood pressure checks, even among those with normal blood pressure. And the positive deviance approaches focus on identifying people who undertake uncommon preventive actions. So among middle-aged women in rural Indonesia, we aim to explore predictors of practicing frequent blood pressure checkups among women, even when they have a normal blood pressure. So the research question is, in rural areas of Indonesia where resources are limited, are there any people who measure their blood pressure? And if there is, what factors are associated with? So this is about the method. So in rural district of West in Indonesia, in December 2016, we conducted a cross-sectional study, and we recruited 530 middle-aged female participants from 2 puskesmas, and inclusion criteria were self-identifying as women, and then age 40 to 64. And data collection was done by a questionnaire. So we developed and administered structures questionnaire in Bahasa Indonesia language, and we collected data by having research assistants ask a participant face-to-face each questionnaire item. and then recording the participants' answers on the questionnaire. So research assistants who are nursing students or public health students in a bachelor degree program collected this data. And we measured frequency of blood pressure checks using a 5-point Likert type scale. So 1 is never, 2 is have never, and then 3 is about once a year, and once in 3 months, and once a month. And we classified cases as positive deviance if they have normal blood pressure and have checked their blood pressure at least once in 3 months. So this taking blood pressure at least once in 3 months is recommended by Indonesian Ministry of Health. And about data analysis, we first calculated descriptive statistics for all variables. We then conducted multivariate analysis by specifying logistic regression model to identify the predictor of practicing frequent blood pressure checkups, while controlling for potential confounding variables. And then we calculated crude and adjusted odds ratio for each variable. So this is the result. So of the 530 people we attempt to recruit, 100% agreed to participate in the study, but we excluded 10 people from analysis because of the missing data of blood pressure check frequency. So among the 520 participants, 265 had normal blood pressure and 255 had elevated blood pressure. The mean age was 51.2 years, and more than half of the participants, 58%, have not completed primary school. So this is about frequency of blood pressure checkups among the 520 people. So the proportion of frequent blood pressure check was higher among the participants with elevated blood pressure status. So the people who take blood pressure measurement at least once in a month, at least once in 3 months is like around 70%. And then among people with normal blood pressure, it was like 60%. But even in rural area with limited resources, and even with a low educational level, and even with normal blood pressure, there are people who regularly measure their blood pressure at least once every 3 months. So I define them as a positive deviance. So after that, this is a result about the predictors of frequent blood pressure checks for non-hypertensive women. So after controlling the confounding factor like age or BMI, education level, or occupation, income, or health insurance status, participants with normal blood pressure was significantly more likely to have had their blood pressure checked every 3 months if they have higher scores on seeking health information and receiving a lot of support from health volunteers. So our study identified predictor for being a positive deviance is receiving support from health volunteers. So health volunteers usually express concern and encouragement and giving suggestions and accompanying community residents when they needed to visit healthcare facilities. And in Indonesia, the community health volunteer is a person chosen by community members who take on the role of mobilizing their community to use basic health services provided at community health posts. So we found the importance of the work of these health volunteers. So So health professionals need to work more closely with health volunteers to support community members' health practices. So we found the importance of utilizing community resources, which is support from health volunteers to prevent and control hypertension in Indonesia. However, further study is also needed to learn more about how or what kind of health volunteer support community health volunteer support is needed in the community. So we held a report session to share results with the community, and we invited faculty member from the STIKES Indramayu, and also students and health center directors, nurses, and health volunteers. And at that time, there are some health volunteers mentioned. So from the research result, we recognized our daily health practices were important. And also health head of KESMAS and nurses mentioned it is very important to collaborate with health volunteers. And we will integrate their contribution into our daily health practices to strengthen our community health efforts. So I visited Indonesia 1 year after the session, and then health center director mentioned she introduced a collaborative system with health volunteers based on these research findings, and she mentioned she received an award from West Java province. So based on this experience, I realized the importance of giving back scientific evidence through research to the community and utilizing the evidence for local practice. So next is about research 3. This is about community health volunteer support for regular blood pressure monitoring in Indonesia using spatial regression models. So as a background, in Indonesia, prevalence of hypertension is high compared to the global average, as I mentioned. And effective strategies for preventing and controlling hypertension are urgently required. So community-based blood pressure monitoring is essential for preventing and managing hypertension in resource-limited settings, where community health volunteers play a crucial role. So numerous systematic reviews have emphasized the importance of home and primary healthcare initiatives in enhancing blood pressure management. However, there is a lack of research on which specific traits of community health volunteers are most effective in promoting regular blood pressure monitoring among community members. So this is the objective of our research. There are 3 aims. The first one is to map the geographic distribution of regular blood pressure monitoring prevalence across sub-districts in Indonesia. The second is to identify the traits of community health volunteers associated with this prevalence. And the third one is to clarify the regional variations in the strengths of these associations. So the finding highlights the most effective community health volunteer support that enhance regular blood pressure monitoring at the community level, so which could provide valuable insights for community-based intervention strategies for preventing and controlling hypertension. So this is the method. The first is about data source and study population. So this ecological study used data from the 5th wave of the Indonesian Family Life Survey, which was conducted in 2014 to 2015. So this Indonesian Family Life Survey is an ongoing longitudinal survey initiated in 1993. And we collected individual data from that Indonesian Family Life Survey and then aggregated this data to the sub-district level. And additionally, we obtained geospatial data to conduct spatial analysis. And next is about variables and data process. The objective variable measured was a percentage of respondents in each sub-district who reported having their blood pressure checks regularly. So this was assessed with a question, how regularly have you had your blood pressure checked? And then respondents could answer either regularly or irregularly. And then the percentage of respondents in each sub-district who answered regularly was counted. So this is about explanatory variables. The explanatory variables comprise 16 community health volunteer traits, and the mean trait values were calculated. So each trait was indicated by the respondent's level of agreement, so measured by a Likert scale, from strongly agree to from strongly disagree to strongly disagree. So the 16 CHB traits as follows. So for example, like I see myself as someone who values artistic and aesthetic experiences. And I see myself as someone who is considerate and kind to everyone. And I see myself as someone who is willing to help people in this village. And in addition to these explanatory variables, adjustment variable included like gender, age, education, marital status, economic status, hypertension diagnosis. So this is about the statistical analysis and visualization. So from the data set of individuals, those with missing data on regular blood pressure monitoring were excluded. So finally, we included 25,829 individuals in the 1,774 sub-districts. And also we included 612 community health volunteers in 259 sub-districts. And first, corpus map were created to depict the geographic distribution of regular blood pressure monitoring prevalence. Then, OLS model, ordinary B-square model, was applied to assess the relationship between the prevalence of regular blood pressure monitoring and the CHV traits. And after that, spatial regression models were employed to identify spatially adjusted associations. And then to evaluate the geographic variation in the regression coefficients between the prevalence of BP monitoring and also CHV traits, we conducted a geographically weighted regression. So maybe spatial analysis may be a new approach, but spatial analysis can improve our understanding of true association based on spatial dependence. So the first law of geography asserts so everything is related to everything else, but near things are more related than distant things. So for example, a sub-district that shows a strong correlation between regular blood pressure monitoring and CHV support will likely to be situated near other sub-districts with similar correlations. So to accurately evaluate these relationships, a spatial regression model can be used to account for spatial effects because traditional regression model may yield invalid results by overlooking these dependencies. And moreover, spatial analysis can illuminate regional variations in the strength of association. So while the traditional ordinary least squares model assume coefficients remains constant across studied area, however, this geographically weighted regression accounts for possible spatial variation in this relationship. So for instance, some sub-districts will exhibit stronger association between regular blood pressure monitoring and support from community health volunteers, while others show weaker association. So this geographically weighted regression is especially effective for calculating locally specific coefficients that capture these variations. So this is about the results and discussion. So first is about sub-district characteristic. The mean age was 35, and most of them are female, and the percentage diagnosed as hypertension was 6.8%, and then a percentage of raised blood pressure if they were by measurement was 90%. So notably, there is a significant discrepancy between this diagnosis and measurement. So this indicates that a substantial number of individuals may have undiagnosed hypertension. And the mean prevalence of regular blood pressure monitoring was 70%, but about 4% of sub-district reported 100% prevalence of regular blood pressure monitoring. So you can see this red region have a high prevalence of regular blood pressure monitoring. Totally, there is a limited access to blood pressure monitoring opportunities, but as you see, 4% of them have 100% of prevalence. So there may be a potential for better solutions. So further investigation into these sub-districts could yield valuable insights. So next is about health volunteer characteristic. The mean age was 53, and most of them are female, and this is a mean of a health volunteer characteristic. So of the 16 traits, higher average score was given to like these variables, including considerate and kind, helpful, and aesthetic. So this is about the results of association between regular blood pressure monitoring and community health volunteers traits using the ordinary regression model and then spatial regression model. So there are three variables which was associated with regular blood pressure monitoring. So higher mean values in considerate and kind and willing to help others indicated a greater proportion of residents regularly monitor their blood pressure in the sub-district. On the other hand, higher mean value in value aesthetic indicate a lower proportion of residents regularly monitor their blood pressure in the sub-district. But this result was not significant in the ordinary regression model, but significant only in spatial regression models. So from this result, enhancing a community health volunteer training with the key traits, this kind of considerate and kind and willing to help others can promote a regular blood pressure monitoring, particularly in resource-limited rural areas. So I heard that usually the training programs primarily emphasizing enhancing knowledge, but it is important to incorporate these key traits into the CHP training curricula in Indonesia. So this figure illustrates the result of geographically weighted regression result, regional variation regression coefficients. So you can see stronger association in the western and northern region of Sumatra Island. So red color indicates a stronger association, and this blue color indicates a lower association. So this association was particularly notable in western and northern region of Sumatra Island. So in the western region, there is a population, Minangkabau people, the largest matrilineal society in the world. So they have a unique cultural structure that values women's opinions and emphasize their essential contribution to decision-making process. So since the majority of community health volunteers in this study were women, so those in Western Sumatra are likely to be respected and influential within their communities. So this kind of a cultural factor is a reason of the difference of regional variation. And then this is about the study limitation. So because this was an ecological study, it may be vulnerable to ecological fallacies. So future research should incorporate individual level data. And then another variable is regular blood pressure monitoring measurement was a subjective response, so which could introduce social desirability bias. So we need objective data also in the future research. Then another limitation is that this data is from 1,774 sub-districts. I know Indonesia have much more sub-districts, so it may limit the generalizability. So finally, I would like to talk about the lessons that I learned from research in Indonesia. So first is about the crucial role of collaboration. So collaboration is not only So collaboration is not only with professionals like faculty members, just professional students, but also community members like Kesehatan. So engaging multiple stakeholders enhance research effectiveness and fosters sustainable solutions. And the second is about the potential positive deviance in resource-limited setting and leveraging existing community resources. So identifying and learning from community members who achieve better outcome despite constraints offers innovative pathways for improvement. So it is important to utilize local assets and knowledge that can optimize intervention and promote community ownership. And the last one is about the potential of spatial epidemiology for region-specific intervention. So mapping regional factors provides valuable insights into geographic disparities and guide targeted intervention. So there may be a potential of spatial epidemiology. And lastly, thank you very much for working with me. And hopefully, I would like to continue our collaborative work in the future also. So thank you very much.
Okay, thank you very much for Mayumi Muzubeni Sensei for your insightful and informative presentations. So now we will move to the Q&A section, which will be conducted in the 2 rounds. In each round, we will provide the opportunity for 3 participants to ask the questions. So you can click the raise icon in the Zoom if you want to ask him directly, or you can put the comment in the chat box in the Zoom room.
Sorry, I have a question.
Okay, Violin. Is it Violin?
Yes.
Violin?
Yes.
You can ask them.
Yes. Good morning, Miss Mayumi.
Morning.
But I'm so sorry I can't turn on the camera because there's a little problem with my laptop. My question is, what is the role of students on your campus in community activities to prevent and control hypertension? And then, have there been any programs or innovation implemented? Thank you.
So is it clear?
So that question is about the role of students to prevent and control hypertension in Indonesia. Okay, thank you very much for the question. So as I mentioned, the collaboration between professional and the community members are very important. So even from the student, even during your student, I think it is very important to communicate with community members, and you better to know about the community needs, and then so that when you become health professions, I think you can better collaborate effectively with the community members and also other health professionals. So in the community, it is, I'm a nurse, but not only a nurse, but many other health professionals are working in the community. So it is, and they have a specific advantage. Each profession have each advantage and each perspective. So it is very important to know the different perspective and to work collaboratively to pursue the quality of life of community people. Thank you.
Yes, thank you very much. Fiolin, is it clear enough about the answers of, or if you want to asking the further questions?
This answer is enough.
Okay, thank you very much.
Thank
So is
you.
there any other one who want to ask directly? Please put the raise hand icon in the Zoom room.
Or even if someone have a different perspective, it is very good opportunity for me to learn, because you know much about the Indonesian culture than me.
So maybe I still a little bit interesting about the positive deviance. I think it is one of the most strategic approach in order to deal with the hypertensions with the limited settings in Indonesia. Like we are heavily limited of human resources and also the research funding for deal with the hypertension. But I think for those people who just start uh, study about the positive deviance, it could be very difficult to us in order to detect the positive deviance within the community. So do you have any like strategy or give us some suggestion how to detect the positive deviance within the community?
Okay, thank you very much for your question. Yeah, yes, it is very difficult to detect who is a positive deviance. And usually it is said positive deviant people are only like 10% or something, so not many in the community. So in order to find the people who conduct uncommon behavior, but which is successful to the community, maybe actually we need to work community people, I think. So they may know about community people and like village chief or health volunteers. So they may know better about the community than health professional, because they are living in a community. So in order to detect the positive deviant people, maybe we need to learn from the community members and leaders in the community.
Okay, thank you very much for the clear statements. And I hope that I can one day also conduct research about it. So, is there any other participants who want to ask into our speakers today, or just put the comment in the Zoom room? So maybe the another question, Sensei. During your study, you have a lot of approach in order to study about the hypertension from the uh, positive deviance until the utilizing the spatial regression model. So my question is, do you have any strategic approach that can be implemented maybe for us who's living in Indonesia and the other future health professionals in this seminar to deal with the hypertension in Indonesia? So what is the strategic approach in order to deal with the hypertension in Indonesia?
What is the strategies to the
Intervention, maybe.
intervention? Yeah. from my research, maybe we found that the support from community health volunteers is important. So maybe we need to work together with community health volunteers to improve the prevention and control of hypertension, because we are nurse, so we are we have a good knowledge of health education, or maybe taking a blood pressure measurement, but community health volunteers know about the behaviors of community members. So they when we have a health post, I noticed that community health volunteers call community members to come to the community health post. So it is important for us to collaborate with that community health volunteers. And also, I think as I mentioned, the training program of community health volunteers is more focused on knowledge. So I think it is better to focus also to attitude, because in our study we found that considerate and kind or willing to help others important attitude for community health volunteers. Is it okay?
Yeah, so yeah, it's okay. So thank you very much. So yeah, I also believe that by utilizing or working together with the volunteer, I think it's ideal in order to deal with the hypertension.
Sorry, Mayumi Sensei, can you hear my voice?
Yes, yes.
Sorry, I have technical problems with my laptop.
Okay.
Yeah, so I very agree with you that one of the intervention that we want to build in order to deal with the hypertension, we have to work together with the health volunteer. So for the other participants, is there any other questions? Yeah, I think that's enough, Sensei.
Thank you very much for
maybe
this opportunity.
let me conclude about our discussion today.
Okay.
So with the higher prevalence of hypertension in Indonesia, effective strategies for preventing and controlling hypertension are urgently needed. And one of the most strategic approach that we can put is over in order to deal with the hypertension is positive deviance. So that's the conclusion of our today's discussion. But before we finish our discussions, there will be a short speech from the head of the Stikers Indramayu. So it is like symbolic in order to give you a certificate. Bapak Rianto, are you ready? Yeah. For Bapak Rianto, the time is yours.
Oke. Ohayou gozaimasu. Selamat pagi, Mayumi-san.
Selamat pagi, Rianto Sensei.
Alhamdulillah bisa ketemu kembali ya. Itu ya. Oke. Thank you very much, Assistant Professor Ms. Mayumi-san, for that great presentation. We really appreciate you coming to speak with us. Here is a certificate to say thank you very much.
Thank you very much, Rianto Sensei, for the certificate. Yeah, I would like to continue our collaboration in the future. So terima kasih banyak.
Kapan Mayumi Sang ke Indonesia? Mungkin testimoni bahasa Indonesia masih hafal.
Kapan?
Mayumi Sang minta bahasa Indonesia.
Yeah, I hope to come to Indonesia very soon, but yeah.
Can you please give us a speech in bahasa Indonesia? Anything that motivate us as the future transformational or any comment of today's meeting in bahasa Indonesia?
Kok nge-lag sih?
Sudah jadi.
Sophie says, I cannot hear your voice clearly.
Kenapa? Ini nge-lag.
So can you hear my voice now?
Yes.
Okay, so can you give a short speech about anything like maybe from today's meeting or a speech about in order to motivate the future health professional with bahasa Indonesia?
Bahasa Indonesia. Mari kita tetap semangat nih untuk kolaborasi penelitian. So mari kita tetap semangat.
Okay. Can you repeat again? Sorry, we have some technical problem in here. Sorry.
Saya bisa bahasa Indonesia sedikit saja, so
Yeah.
but
It's okay.
mari kita tetap semangat untuk kolaborasi penelitian.
Yeah. Hai, arigatou gozaimasu.
Arigatou gozaimasu, terima kasih.
Arigatou gozaimasu.
Arigatou gozaimasu, terima kasih.
Hi, so on behalf of the committee, I would like to sincerely thanks to the Associate Professor Mitsutani Sensei for your valuable time, effort, and insightful presentation from today's meeting. And we hope that the knowledge that you share today will be useful and inspire us in our professional practice. So let's continue to collaborate from each other to improve the healthcare together. Domo arigatou gozaimashita.
Hai.
So for Associate Professor Mitsutani Sensei, now you can leave the Zoom room.
Okay,
Hai,
thank
arigatou
you.
gozaimashita.
Hai.
So, ladies and gentlemen, now we are moving to the next speaker in the session 3. In this section, she will elaborate about the collaboration of health worker in preventing the congenital hypothyroidism in children. Without further ado, it is my pleasure to introduce our invited speaker for today's session. The Assistant Professor Nanda Yansih Putri, who are currently working as the lecturers in study program of midwifery Sidikas Indramayu. She conduct many study about low birth weight in Indonesia. We hope that this session will be informative, interactive, and helpful for our participants in understanding about the low birth weights. Mrs. Nanda, you have 45 minutes for presentations and 10 minutes for Q&A section.
Good morning, everyone. Halo, good morning everyone.
Good
Good morning, Bu Randa.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Okay, thank you.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, first I want to introduce myself. My name is Nandayansi Putri. I'm a lecturer in the midwife program study in Stikes Indramayu. Okay, we will discuss about collaborating with women healthcare professional in preventing congenital hypothyroid in newborns. Okay. Before the start of the newborn screening program, the incidence of congenital hypothyroids as diagnosed after clinical manifestation is in the range of 1 in 7,000 to 1 in 10,000. With the advent of newborn population screening, the incidence was initially reported to be in the range of 1 in 3,000 to 1 in 4,000. With more experience from state, regional, and national screening program, it has become clear that the incidence varies by geographic location. Several cases found the incidence nearly double in twin births, 1 in 876, as compared to singleton 1 in 1,765, and even higher with multiple births, 1 in 575. Mothers more than 39 years had a higher incidence, 1 in 1,328, compared to younger mother, less than 20 years, in 1,703. The incidence was higher in preterm versus terminal infant. It is not clear, whatever, that the congenital hypothyroid in preterm infant is transient or permanent. However, as the incidence of preterm birth has increased by approximately 20% of the last 20 years. This might contribute to the report overall increase in incidence. Nearly all screening programs report female preponderance approaching 2 in 1 female to male ratio. This is a congenital hypothyroid in Indonesia. Global, the incidence in every 3,000 until 4,000 live births. And then in Indonesia, it is estimated to be around 1 in 2,513. And then increased hypothyroid case due to reduction in the TSH screening time in limited through the newborn screening program. The worldwide prevalence of congenital hypothyroid is estimated to be close to 1 in 3,000. Different in the prevalence of congenital hypothyroid can also be influenced by ethnic and racial difference. From 2018 to 2022, any 56 cases of congenital hypothyroid were identified in reference laboratory tests. Most of these cases were diagnosed late, resulting in impaired growth and motor development, as well as intellectual disabilities. In 2022, the incidence rate in Indonesia was 1 in 12,724, with congenital hypothyroid screening coverage of 2.3%. This incidence rate could certainly be higher or approach the global average if congenital hypothyroid screening coverage reaches at least 90% of all target population. Okay. And what is congenital hypothyroid? Yeah, congenital hypothyroid or CHE is a disorder in infant present at birth caused by insufficient secretion of thyroid hormone by the thyroid gland and decreased action of thyroid hormone at the cellular level. one of the main causes of preventable mental retardation. Yeah. Most neonates do not show obvious signs of hypothyroid, making it difficult to diagnose the condition if diagnosis and treatment are not initiated within a few weeks of birth. This is because newborns have residual thyroid hormone, making the symptom and stage of thyroid hormone deficiency non-specific. Therefore, newborn screening and immediate treatment with 2 weeks of birth will have the best outcome. And then this is classification of congenital hypothyroid, and then any three classification. And the first, thyroid dysgenesis, that is thyroid agnesia, absence of the thyroid gland, and thyroid hypoplasia, that is small thyroid gland, and ectopic thyroid, that is thyroid gland not its normal location. And the second classification, that is this hormonogenesis. The thyroid gland is hormone normally, but cannot produce thyroid hormone efficiently due to a genetic disorder. And three classification there is iodine deficiency. Iodine deficiency in the diet of pregnant women can cause hypothyroid in babies because iodine is essential for the production of thyroid hormones. Okay. Congenital hypothyroid is classified in permanent and transient congenital hypothyroid. Permanent congenital hypothyroid refers to a persistent deficiency of thyroid hormone that requires lifelong treatment. Transient congenital hypothyroid birth. Transient congenital hypothyroid refers to a temporary deficiency of thyroid hormone discovered at birth, but then recovery to normal thyroid hormone production. Recovery to euthyroidism typical occurs in the first few months of years of life. Next, the role of thyroid hormone in the body. The first, have regulate body temperature, and then maintains the digestive system and bowel movement. The second, the third, that is maintains the cardiovascular system and then stimulate and to grow. Next, ensure health appetite, and then ensure the development of the brain and the nervous system. Okay. Thyroid hormone is essential for normal metabolism throughout life, for physical growth during childhood, and for brain development in utero and during the first 2 until 3 years of life. Thyroid hormone disease regulates growth, myelination of the nervous system, metabolism, and physiology. This hormone function in nearly every organ system. The fetal thyroid gland begins producing thyroid hormone in the second trimester, and the dependence of maternal thyroid hormone decrease in the second half of pregnancy as the fetus matures. The hypothalamic pituitary thyroid axis result in increased production of the hormone thyroxine, also known as fetal T4. Maternal thyroid dysfunction, especially in the first half of pregnancy, may impact the child's neurogative development. That is the role of thyroid hormone in the body. Okay, next, that is a symptom of babies born with congenital hypothyroid. It is known that 95% of congenital hypothyroid does not show specific clinical signs and symptoms at birth, and the duration of early intervention to prevent mental retardation is short. Therefore, most development countries have implemented neonatal screening program for early detection of hypothyroid. Detecting thyroid hormone deficiency early in life through congenital hypothyroid screening allow for early treatment to prevent brain damage. Congenital thyroid hormone deficiency can be caused by impaired thyroid gland development or thyroid hormone synthesis. Timely investigation, diagnosis, and treatment of maternal, fetal, and neonatal thyroid dysfunction is crucial to ensure rapid stabilization of normal thyroid function. If the risk of fetal death and neonatal hypothyroid, as well as medium and long-term morbidity in hyper and hypothyroidism. Okay. Okay, in this slide, any three picture, A, B, and C, that is clinical manifestation. The picture one, that E, 3-month-old infant with untreated congenital hypothyroid. Picture demonstrate hypotonic posture, mixed edematous facial, macroglossia, and umbilical hernia. And the picture B, that is same infant, close up of face, showing mixed edematous faces, macroglossia, and skin mottling. And then the picture C, same infant, close up showing abdominal distension and umbilical hernia. Okay. And then this is picture. Any manifestasi klinis the first 2 weeks, after month of age, after 3 month age. Ini eyes, hand, and apa? Tooth ya. Okay. Next, why should hypothyroid screening be performed on newborns? The importance of congenital hypothyroid screening. Congenital hypothyroid screening is a laboratory test performed on newborns. It is conducted within 48 until 72 hours to detect whether the baby has congenital hypothyroid or not through a blood test using a sample taken from the baby's hair. And then prompt treatment will not have a serious impact on the baby growth and development. The goals of the congenital hypothyroid screening program are to detect infant with thyroid dysfunction early, provide thyroid hormone therapy as soon as possible, ideally before 2 weeks of age, prevent long-term impacts such as mental retardation, which are irreversible if treatment is delayed. The benefit of this program are enormous, but from a public health and economy perspective. Healthy children have maximum cognitive and social potential. Thirdly, the reduction the long-term burden on the state. Therefore, the WHO also recommended neonatal screening, including for congenital hypothyroid, as part of National Child Health Program. And then this is congenital hypothyroid diagnosis algorithm. Okay. Diagnosis algorithm, the diagnosis of congenital hypothyroid begin with either abnormal newborn screening test result or a clinical suspicion of hypothyroid, leading to the serum thyroid function test, typical TSH and free T4 to confirm the diagnosis. If a diagnosis of primary or secondary congenital hypothyroid is confirmed, other diagnosis studies can be undertaken to determine the underlying etiology. How if the baby test positive for congenital hypothyroid? The first, anamnesis or medical history, and then physical examination by a doctor, and then a confirmation test of T4, free T4, and serum TSH. The next referral to a pediatrician, and then education for parents. The next reanamnesa asks there is not thyroid disease in the mother and family, and then taking anti-thyroid medication during pregnancy or not, residence in iodine deficiency or non-deficiency area, and then last, other abnormalities in newborn. This is physical examination. Terlihat seperti letargi, jaundice, macrolingualis, umbilical hernia, flat nose, constipation, dry skin, and dull skin. And then a sleep choke, hoarse voice, hypotonic, midden, fontanelli, pot belly, sleep cold, puffy face, and then udim scoratum. Next, that is supporting examination. The first thyroid examination, and then thyroid ultrasound, radiology, and antibodies. Okay. The thyroid ultrasound can confirm enlarged gland indicating this hormone genesis. Maternal autoimmune thyroid disease may be associated with the production of thyroid receptor blocking antibodies. Okay, in this picture, I'm sorry, I make Indonesian language. Okay. Do pregnant women need iodine supplementation during pregnancy? The main iodine supplement for pregnant women depends on iodine salt. Iodine requirement for pregnant women increased from 170 to 250 micrograms per day. This additional iodine can be in the form of iodine supplementation with other micronutrients in addition to iodine fortification of pregnant women in the additional food given to all pregnant women. The next therapeutic goals, congenital hypothyroid screening. The first, restore essential metabolic function normal in a short time. Second, optimizing child growth and development. And the last, restore normal level of biological maturation. And then this is administration of levothyroxine. The first, regular administration of levothyroxine in the morning. Written instruction to parent must be clear, can be ground and mixed into breast milk. Doses according to pediatrician instruction. And then parental education. The first, explain the case of congenital hypothyroid. The second, the importance of regular check-up on schedule, and then method of administration, and the importance of complying with the administration of thyroxine medication, and the importance of diagnosis and treatment, and then may non-spot treatment unless ordered by a doctor, the last sign of deficiency and excess of thyroid hormone. Okay. The role of health workers in the context of health promotion, consistent and repeat education through cadres and healthy workers can set the collective awareness of the community about the importance of maternal and childhood. The World Health Organization also said that every pregnant woman should receive sufficient information about preventive measures during pregnancy and postpartum, including newborn examination. Educational intervention, that is, training cadre on congenital hypothyroid screening, provision of educational media, and then integration of congenital hypothyroid screening information into pregnancy checkup, and then the last, cross-sectoral advocacy to raise awareness of congenital hypothyroid screening for maternal and childhood. And then collaborating in preventing congenital hypothyroid. The first collaborating in preventing congenital hypothyroid in Indonesia involve various parties, including the Ministry of Health, local government, health staff, facilities, and the community. The second, the goal is to ensure that all newborns undergo congenital hypothyroid screening for early detection, timely treatment, and prevention of neurodevelopment disorder and mental retardation. And three, this collaboration include public education, providing access to free screening, improving the skill of health workers, and ongoing monitoring. Collaborating in preventing congenital hypothyroid. Government mandating congenital hypothyroid screening as part of essential neonatal service and covering the cost of screening and treatment through the national health insurance, so that all babies can access it free of charge. And the second, healthy facility service, responsible for collecting blood sample from the baby's heel and analyzing thyroid hormone level, providing information to parents about the importance of congenital hypothyroid screening and the diagnosis of congenital hypothyroid, as well as the importance of early treatment with LT4 to prevent neurodevelopment disorder, referring infant diagnosed with congenital hypothyroid for additional testing and appropriate management. And three, public education and awareness, educating the public, especially pregnant women, about the importance of congenital hypothyroid screening to ensure the next generation grow healthily and optimally. Utilization of information sources. And then the last time, then integrate system and service. The government and relevant parties provide training and orientation to improve the knowledge and skill of healthcare workers in implementing congenital hypothyroid screening. This emphasis regular follow-up visit and laboratory monitoring SH and people to monitoring therapy response and ensure a proper drug dosage. Okay, enough. And then thank you for your attention. I will back to moderator.
Thank you very much, Ms. Nanda, for your very insightful and informative presentation. So we will now move to the Q&A section, which we'll conduct in the round. In each round,
As usual, we will provide the opportunity for participants for their questions.
so if you review or you want to ask
In Ms. Nanda directly,
you can click the raise hand icon to do so, or just if you want to put the questions in the chat box, you can type in the chat box. Kayaknya nggak apa-apa pakai bahasa Indonesia. Anyone who want to asking the questions, please raise your hand. Okay, Saktika, you can ask to Miss Nanda directly.
Okay, thank you. Hello, I'm Kartika from Indonesia. I have question, how is the implementation of the CSC program in Indonesia? Thank you.
So is it clear enough for Ms. Nanda? So what is the programs that Indonesia have in order to deal with the hyperthyroidism?
Okay, it's clear, Miss Sophie. Okay, thank you, Miss Kartika. Okay. Implementation of the congenital hypothyroid screening program in Indonesia. The coverage of the congenital hypothyroid screening program in Indonesia is still limited and tends to be focused on large hospitals or urban area. This low coverage is influenced by various factors, including inadequate outreach to the community and primary health care workers, lack of understanding among healthy workers and pregnant women about the benefit of congenital hypothyroid screening, and then the suboptimal integration of congenital hypothyroid screening into antenatal care service at community health countries.
So is it clear enough to consider? Or
Yes, Miss, enough. Thank you.
there are some
recently conducted by the government of Indonesia in order to deal with the hypothyroidism.
is there any others? Please raise your hand or clicking the raise emoticon in the chat in the Zoom, or leave the comment. Leave the questions in the comment box. So Miss Nanda, can I have a question? Miss Nanda. So during during your as a midwifery, I mean, what is the most challenging when you taking care of the children with the hypothyroidism? Okay.
Repeat again, Miss Sophie, please. Okay.
As midwifery,
Yes.
what is the most challenging thing
Challenging.
in you facing or taking care of the patient with the hypothyroidism?
Hypothyroid. Okay. Okay, thank you, Miss Sophie. And to preventing congenital hypothyroid in newborns, any to do as midwife to education for a woman pregnant, for a summer prenatal care, and then many to do as midwife to apa ya care woman pregnant. Okay.
Yeah. Okay. So thank you very much.
Yeah.
So
Thank you very much. So we will see the question from the comment box. This is from Nichma from Speakers Indramayu. I have questions. The question is, as midwife, what role do you play in reducing the incidence of congenital hypothyroidism? Thank you.
Okay, thank you, Ms. Sophie. Okay.
I'm so sorry. Okay, thank you, Miss Nisma, for your question. More effective and sustainable educational intervention are needed. The strategies could include training health cadre on congenital hypothyroid screening and their role in community education, providing simple education, media, leaflets, poster, and infographics, and then integrating congenital hypothyroid screening information into antenatal care examination and cross-sector advocacy to ensure congenital hypothyroid screening is a priority for maternal and child health program. That's it. Ms. Nisma, please.
Miss Nisma, is it?
Is there any additional statement that you want to add?
Miss Nisma?
Do you hear my report?
Yes, I think it's
Thank you very much for your clear explanation.
so the other questions. Mi Giri Rati Septia.
Yes, hello, Miss. Does my voice sound?
Yeah.
Clear.
Oke. Selamat pagi, Ibu.
Morning. Pagi. Oke, Giri.
Oke. Miss, how can pregnant women prevent congenital hypothyroidism in Indonesia or in international? Thank you.
Okay, thank you, Miss Giri. Okay, thank you your question, Miss Giri. A woman prevent congenital hypothyroid, yeah. Prevent congenital hypothyroid, pregnant woman needed to ensure adequate iodine intake through iodine salt of supplement as recommended by their doctor and undergo congenital hypothyroid screening for their babies after birth. For mother with hypothyroid, dosage adjustment for thyroid medication may be necessary during pregnancy and should be done under the supervision doctor. That is Miss Giri. Are you midwife?
Yes. Yes.
Okay.
Thank you, Miss.
Okay, thank you too.
Thank you very much. Is there any different questions from I think it's enough.
Thank you.
Let me conclude about our presentation.
So, in conclusion, hypothyroidism in newborns, often due to the congenital hypothyroidism, can cause serious development delay if not detected and treated early. So, it is routine newborn screening followed by the prompt thyroid hormone replacement is crucial to support normal growth, brain development, and overall health. On behalf of our committee today, I would like to sincerely thanks to Ms. Nanda Sinte. For your valuable time, effort, and
insightful contribution.
Okay,
We hope that the knowledge you share today will be useful
and inspire all of us in our professional practice. Let's continue to collaborate each other to improve our healthcare together. Thank you very much. So today, in the session 3 of our discussion is finished, I will give back the discussion session, the time to the MC. Thank you very much.
Thank you very much, Nurse Sophie Octaviani, PhD. Ladies and gentlemen, that was an excellent session 3. Professionally guided by Nurse Sophie Octaviani, PhD, we sincerely appreciate her effort in making decisions smooth and informative for all participants. We will now have a short break before session 4 begins. Please take this time to stretch, have a refreshment, or attend to your needs. The break will last for 2 hours. and we will resume promptly afterwards. To all participants, please join the Zoom meeting for the session 4 at 1 p.m. Thank you very much. Ladies and gentlemen, we are now ready to begin session 4 of our webinar. It's my honor to introduce the moderator for this session, Nurse Wiwi Nuraini MCAP, who will guide us through the presentation and discussion, ensuring that everything runs smoothly. I invite Nurse Wiwi Nuraini MCAP to lead this session. Ms. Wiwin, screen and time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you to Master of Ceremonies who has authorized me to guide the discussion at this session. The Honorable ladies and gentlemen, good afternoon everybody. It is my great pleasure to welcome you all today's session on comprehensive responses to non-communicable disease, the role of multidisciplinary collaboration in prevention and care. Ladies and gentlemen, non-communicable disease continue to be the leading causes of mortality and morbidity worldwide. Addressing these challenges requires not only medical intervention, but also a strong collaborative approach that involves diverse disciplines, ranging from healthcare providers and researchers to policymakers and community organizations. Today, we will explore how multidisciplinary collaboration can transform the way we prevent and manage NCDs. By integrating knowledge, skills, and perspective across different fields, we have the opportunity to build more effective, patient-centered, and sustainable systems that lead to better outcomes for individuals and communities. As your moderator, I look forward to guiding our discussion, encouraging meaningful dialogue, and highlighting the innovative ideas and best practices shared by our esteemed speakers. Together, let us reflect on how collaboration can move us closer to healthier societies and stronger health systems. Before we continue to the presentation session, let me introduce our speakers for this noon. First, Nurse Rido Kunto Prabowo, Magister Keperawatan, Spesialis Keperawatan Medikal Bedah. Welcome, Mr. Rido.
Hello, Ms. Wiwin. Good afternoon.
Good afternoon. I'm so happy to see you here. Are you ready for this session?
Ready.
Okay. Wait a moment. Please hold on because I will introduce our second speaker. She is Dr. Palapija, BDS MSc. Please welcome Dr. Palapi.
Hello.
Hello. What
Hello.
time at your place now?
So it's 7:20 now in the morning.
Yeah. Maybe as your routine, you are wake up, yeah, or maybe at breakfast time.
Yeah, it's nearly breakfast time now. Yeah.
Okay, thanks. Okay, thank you for your coming in this event. Okay, ladies and gentlemen, I will explain the rule of this session. Each speaker will have 45 minutes for the presentation. Please keep your microphone mute while the presentation. Then we will give 15 minutes for question and answer session. You can ask directly or by chat box. Okay, let's start to the first topic. First presentation will be delivered by Nurse Rido Kunto, Spesialis Keperawatan Medikal Bedah. And before we see how he explained his presentation. Let me introduce more detail about him. He is a lecturer in Indramayu College of Health Science. He is expertise in cardiology, in nursing, and he has so many publication and also research related surgery and nursing, and also about cardiology. Okay, and for this occasion, he will deliver about integrating complementary therapies into nursing care for non-communicable disease. Okay, Nurse Rido, it is your time, please.
Thank you very much, Ms. Vivin. Good afternoon, everyone. Before presenting the topic, I would like to introduce myself. My name is Rido Kunto Prabowo from Department of Nursing, Indramayu College of Health Science. My expertise in medical surgical nursing, in specialty in cardiology. On this occasion, I will present about integrating complementary therapy into nursing care plan for non-communicable disease or NCD. Okay, in Indonesia, according to data from the Ministry of Health in 2024, there has been an increase in prevalence of NCD and the prevalence of hypertension, stroke, cancer, and diabetes mellitus in generally. Meanwhile, in Indramayu, according to data from the Indramayu District Health Office in 2022 and 2023, the most common non-communicable disease are hypertension and diabetes mellitus. Indramayu is located in the north coast of Java. Many people often consume salty food that cause hypertension. So hypertension and diabetes mellitus are NCDs commonly found in Indramayu regency. And then the nursing department at Indramayu College of Health Science has developed a vision related to intervention that can be provided to the community or patient, one of which is to treat non-communicable disease or NCD. The vision is produce professional nurse, excellent in the field of complementary nursing, religious, and be able to combat globally by 2045. Department of Nursing equip students with complementary nursing training to help solve health problem, especially for NCD. And the bachelor degree program in nursing and the nursing profession program have been equipped with learning and training related to complementary nursing. As an introduction, integrating complementary therapy into nursing care for NCD improve patient outcome by managing pain, anxiety, fatigue, nausea, vomiting, and stress, maybe reduce blood sugar level or blood pressure, while also empowering patient and strengthening the nurse and patient relationship. This holistic approach, which include practice like acupressure, acupuncture, yoga, mindfulness, and the other complementary therapy, must be evidence-based and implement with a whole of system approach to ensure safety and effectiveness. Key aspects of integration include patient involvement, proper education on complementary alternative medicine practice, and a focus on a patient and center strategy that respect individual needs and culture belief. There are 4 benefits of integration complementary therapy into nursing care. Number 1 is improve patient outcome. Complementary therapy can significantly reduce symptoms like chronic pain, anxiety, maybe sleep disturbance, and maybe reduce blood sugar level or blood pressure. And then number 2 is enhance patient autonomy. Patient feel more empowered and involved in their recovery when they can actively participate in their care. And then number 3 is strengthened nurse and patient relationship, a holistic approach and clear communication leading to a more collaborative healthcare experience. And then the last is address NCDs holistically. By considering the person as a whole, nurse can provide care that aligns with their life story, emotional, culture, belief, promoting adherence to treatment. And then there are 5 keys consideration for integration. Number 1 is education and evidence. Nurse need to be educated on complementary therapy to integrate them safely and effectively, focusing on evidence-based practice. And then patient-centered approach. The integration should involve the patient in decision making and consider their personal and environmental factor. And then holistic perspective. Holistic perspective focus on the totality and integrity of the person, not just the disease, to promote adherence and improve well-being. And then collaboration, a whole of system approach involving policymaker, educator, and the private sector in crucial to addressing the NCD. And then safety, always assess potential risks and contraindication in patient. Complementary therapy is a combination between conventional medicine and alternative therapy. Conventional medicine is common healthcare such as medication and surgery performed by medical professional and rooted in scientific evidence. And then alternative medicine is a non-conventional practice used to complement, not replace by conventional medicine. And then complementary therapy are holistic care model. The holistic care model is a comprehensive approach to healthcare that considers the whole person, not just their illness, with a focus on integrating the physical, mental, emotional, social, and spiritual dimension of the patient. And then nurse can use our hands, heart, and head in creating healing environment, scientific skill and spiritual commitment, attitude and perspective, holistic, and take care of yourself. There are many factors influencing nurse use of complementary alternative therapy. Number 1, maybe personal use, maybe nursing, midwifery, or public health use complementary or alternative therapy. And then perception of legitimacy, efficacy, and benefit. And then knowledge and experience, nurse stress and environmental stressor, general open toward therapy, concern about legal issue, and then ethical issue, and lack of equipment, time, and training. There are 4 basic concepts in complementary and alternative therapy. Number 1 is balance. Balance is a core belief in complementary and alternative therapy is the importance of balance between mind, body, and spirit to maintain health and well-being. And then spirituality, complementary and alternative therapy recognize that spiritual and psychological factor significantly influence health. And then number 3 is energy. This concept involves the belief in energy field or biofield within and around the body, as well as the use of external energy source to promote health. And then number 4 is breathe. Control breathing technique consider a vital component of many complementary and alternative therapy for their mind-body effect. And then classification of complementary therapy. National Center for Complementary and Alternative Medicine categories that complementary and alternative therapy into 3 broad groups. Number 1 is natural product, such as herbal medicine, vitamin, minerals, dietary supplement, or probiotic. And then mind-body therapy, imagery, meditation, yoga, music therapy, or maybe murotal therapy, and then art therapy, acupressure, acupuncture, and the other mind-body therapy. And the last, manipulative and body-based therapy, such as chiropractic medicine or massage. This is implementation complementary therapy in Indramayu College of Health Science. This application of complementary alternative medicine by nursing student based on research result. Number 1 is mind-body practice, imagery, music therapy, murotal therapy, finger grip relaxation, and acupressure. Music and murotal therapy to reduce anxiety, finger grip relaxation to reduce pain and anxiety, acupressure to reduce nausea and vomiting in patients with hypertension, diabetes mellitus, cancer, maybe congestive heart failure, and other NCD. Number 2 is manipulative and body-based therapy in student in Indramayu College of Health Science. Application foot massage and back massage to reduce blood pressure or reduce blood sugar level in patient with intradialytic hemodialysis. And then number 3, natural product, aloe vera gel and warm ginger compress. Application of aloe vera gel to reduce symptom of pruritus in chronic renal failure, and warm ginger compress to reduce pain level. And the other therapy, aromatherapy, the use of aromatherapy, lavender or jasmine to reduce pain and anxiety in patients with chronic kidney failure or diabetes mellitus type 2. In nursing management, the role of nursing with respect to complementary and alternative therapy is evolving. Rules of the nurse may include number 1 is assessing a patient use of complementary and alternative therapy and the possible risk of complication or adverse interaction with conventional therapy, and then promoting safety and serving as a resource. Number 3 is providing holistic self-care and holistic nursing care. and then serving as a provider, and number 5 is participating in research. And then nurse related issue in complementary therapy. Number 1 is lack of information in nursing education related to complementary and alternative medicine, and not enough time, not enough training, not enough knowledge, and then ethical issue and reluctance of peers and physicians. The strategy for incorporating complementary and alternative therapy into nursing curricula. Number 1 is provide complementary and alternative medicine learning opportunities for faculty through workshop, webinar, seminar, and online learning modules. And then revise course objective to reflect complementary and alternative medicine intervention in patient care. And then encourage complementary alternative medicine intervention in care plan whenever appropriate. Include specific complementary and alternative medicine information relevant to theory and skill course of clinical experience. Look for inclusion of complementary alternative medicine in textbook before adoption. Include complementary and alternative medicine article as a part of required readings. Provide adequate library resource such as complementary alternative medicine journal, and include basic complementary alternative medicine principles on tests. As a conclusion, complementary therapy are commonly used by patients with NCD to managing pain, anxiety, fatigue, nausea, vomiting, stress, reduce blood pressure and blood sugar level. And then this is therefore important for the practitioner to be familiar with complementary therapy, with their proposed mechanism of action and effectiveness, and with the potential risk of adverse effect and drug interaction. Okay, maybe that conclude my presentation. Thank you, Ms. Wiwin. And now return to the moderator.
Okay, you're welcome, Mr. Rido. It's so briefly presentation and so interesting, especially talk about complementary therapy, yeah, because it is one of the most or maybe viral in the healthcare system. Okay, ladies and gentlemen. Let's continue to the discussion session. Now we give you all participants the opportunity to actively ask questions, either directly raise hand or through the chat box.
Sorry, I have question.
Okay, please mention your name and your question.
Okay, thank you for the apologies. Good afternoon, Mr. Rido.
Good afternoon.
My name is Violin Asri Zahrani from Indonesia. I want to apologize beforehand. I can turn on the camera because there's a little problem with my laptop. I have a question for you. The question is, how can nurse assess the effectiveness of complementary therapies in patients with non-communicable disease? Thank you.
Okay, thank you, Violin. Mr. Rido, will you answer the question now, or need we to collect some question?
Okay, I want to answer now.
Oh, okay.
Very
Please,
good
your
question
chance.
from Violin. Thank you. The question is, how can nurse assess the effectiveness of complementary therapy in patient with NCD? Nurse can assess the effectiveness of complementary therapy in patient with NCD by number one is monitoring patient outcome and symptom management, and then using standardization assessment tool and gathering patient feedback and self-report outcome, and then collaboration with other healthcare provider to evaluate the impact of complementary therapy on patient care.
Okay, thanks, Mr. Rido. Miss Violin, is it clear or any feedback from you?
Yes, is it clear? Thank you.
Okay, thanks. You're welcome. Okay, ladies and gentlemen, we will still give you a chance to give you a question. And now we have a question in chat box. Let I read. Okay, the question comes from Laila Firdayanti. I would like to ask, could you please explain the steps for integrating complementary therapy into, I think it's similar with the question that given from Violin.
Different, Miss different.
Yeah, different. Yeah, okay. Please, could you please explain about the steps for integrating complementary therapy into nursing care plan for patients with NCDs? You can answer now.
Okay, thank you, Laila Firdayanti. Very good question. A step for integrating complementary therapy into a nursing care plan for patient with NCD. Number one is assess patient need and preference, evaluation the patient psychical, emotional, and spiritual needs, and identify their preference for complementary therapy, and then develop a comprehensive care plan, select evidence-based practice, and then collaborate with interdiscipline team, and then implementation complementary therapy, integrate complementary therapy into the patient care plan, such as mindfulness, message therapy, or the other, and then monitoring and evaluate outcome, regularly assess the patient response to complementary therapy and adjust the care plan as a needed optimal outcome, and then educate patient and family, provide patient and their family with information about complementary therapy, and then the last is document and document the use of complementary therapy in the patient medical record. Okay, Miss Wiwin, thank you.
Okay, thanks, Mr. Rido. Okay, Laila Firdayanti, is it clear? Okay, you can give feedback directly, or maybe you can answer your feedback on the chat box. Okay, thank you for Laila. Now, there are still several questions from Eva Noviana. Okay, Eva Noviana asks about, are patients who use complementary therapies more compliant with conventional medical therapy, or are there risks of neglecting primary medications? Okay. And maybe I will read for another question. It comes from Amalia Rizky Soliha. She asked about how to choose good evidence-based nursing for integrating complementary therapies into nursing care plans. Okay, thanks for Eva and Amalia Rizky, and for the others participant, you can also ask while Mr. Rido answer the question. You can type your question on the chat box. Please, Mr. Rido, you can answer for the for both of the question.
Okay, thank you, Ms. Amalia Rizky Soleha, for the question. How to choose good evidence-based nursing for integrating complementary therapy into nursing care plan? Okay, to choose the good evidence-based nursing for integrating complementary therapy into nurse care plan, number one is search for systematic review. Look for systematic review and meta-analysis that summarize the best available evidence on the effectiveness of complementary therapy, and then use reliable database. Search reliable database such as Scopus or PubMed to search article and study on complementary therapy, and then evaluate study quality, consider study design, and then look for relevant and applicability, and then consult the professional guidelines, and stay up to date to the journal or article in complementary therapy.
Okay,
then,
thank you. Next,
from Eva for Stikers Indramayu, I have question. The question is: are patients who use complementary therapy more compliant with conventional medicine or under risk of neglecting primary medication? In my slide, complementary therapy is a combination between complementary and conventional medicine. Complementary therapy is used as a support, not a replacement or support conventional therapy. And then the patient is high health conscientious and want to enhance treatment outcome. There is open communication between the patient and healthcare provider. The conclusion is complementary therapy is used by support the conventional therapy.
Okay, thank you, Mr.
Miss.
Yeah, okay, Eva, I hope that has clear, yeah. Or if you have any feedback, you can give your feedback on the chat box. Thank you. And we still give you a chance to make some discussion. Maybe we still give you once more chance for the question. Okay. Yeah, thank you, Miss Eva. Okay. Yeah. Okay, we still waiting for another question, or maybe the topic that has delivered by Mr. Rido. It has clear enough for all of you. So, can we close this session, Mr. Rido? Or maybe you have some statement before you closing your presentation?
Enough, Miss Vivin. In the last slide is as conclusion.
Okay, thank you. Okay, ladies and gentlemen, we have finished for the first topic from Mr. Rido. Let me summarize the discussion and the presentation. So, integrating complementary therapies into nursing care for NCDs offers a holistic approach that addresses not only the physical, but also the psychological, emotional, and social dimension of patient health. By combining evidence-based conventional treatments with safe and appropriate complementary practices, such as relaxation techniques, mindfulness, massage, or nutritional counseling, nurses can enhance patient well-being, improve treatment adherence, and reduce symptom burden. Okay, thanks a lot for Mr. Rido. Please still join with us because in the last session, we will give a certificate for you. Thank you. Now, ladies and gentlemen, let's move to the second topic. The second topic will be delivered by Dr. Palavija, and the topic is strengthening multidisciplinary collaboration in NCDs prevention and care, building an integrated model for better health outcomes in England. Okay, Palavi? Yeah?
Yeah.
Yeah, okay, and before you start your presentation, I will tell about your background first. Dr. Palapi works as coordinator histology of cancer specimen pathway in Bedfordshire Hospital and NHS Foundation Trust in United Kingdom. She graduated her Magister of Science in Global Healthcare Management in Coventry University. Okay, Dr. Palapi, now we will give you a chance to present your topic, please.
Thank you.
Palavi, maybe you need to refresh, or maybe you can stop your share screen and then try to start again. Okay, ladies and gentlemen, please waiting for a while because there is some problem for a signal from Palapi. And while we are waiting, you can maybe take a rest. Oh yeah, thanks.
Yeah,
Palapi
sorry, there
some...
was a network issue, I think. Sorry.
Yeah,
I'm
is
just
it
sharing
okay?
my
It's
screen.
okay.
Yeah, can you all see it?
Yeah, we can see it clearly.
Yeah. So first of all, thank you for inviting me for this webinar. It's a great honor for me. And firstly, I will introduce myself. So my name is Dr. Pallavi Jha, and I have done my dentistry, and after which I did my MSc in Global Healthcare Management from Coventry University. So there I worked as a project supervisor and assistant lecturer for 2 years. And currently I am working with the NHS in the Cancer Services Department. So my role is to prevent any delays in the cancer specimen pathways so that the patients are treated in time. So my title is Strengthening Multidisciplinary Collaboration in NCD Prevention and Care. So that means we are building an integrated model for better health outcomes. So as we all know that our fellow speakers have discussed a lot of things, a lot of important things about the hypertension in Indonesia, the research, and some of the models of complementary therapies, and how to screen a newborn for hypothyroidism, etc. So my topic will be just a part of the puzzle, I would say, and to just make all of them together and help to know that why collaboration is required to treat the non-communicable diseases. So let's start with a small story I will like to share with you. So few years ago, there was a patient. I don't want to name it because of the confidentiality. So let's say a XYZ, and he was diagnosed with the hypertension. So as a normal patient does, he did everything. He went to the doctor. He received the prescription for himself, and then he took medication as he was told to do. But when he came back 6 months later, and his blood pressure was not controlled. So in this case, we will think, can we all think why it was not improved? Because it was the only doctor who told him about taking medication, but most of the important things he forgot to tell him. So the first, he didn't realize that he was eating high sodium intake, and because he was not financially very good, and food were cheaper, convenient, and he was just not told about any nutrition advice. So after that, when a nurse followed up with him, and he was referred to the nutritionist, the dietitianist, and then he started following the proper diet and the regular checkups, and with that really made a difference for his hypertension prevention. So we can say that it's not just the pill, it's all about the people who are giving him advice, who are taking the regular follow-ups, and the patient himself who is following whatever is told to him for better health outcomes. So the next one I want to say is this is a brief recap of what we have done, as I previously discussed with all of you. So let's see an overview of the non-communicable diseases. So non-communicable diseases are leading cause of morbidity and mortality worldwide. So if we'll see in Indonesia, it's about in 2021, as per a WHO report, it was around 74 to 75% of the global death, even with compared to the COVID pandemic time. And the other thing is it is very complex. It requires multifactorial and lifelong management. So it's not just you are just taking medicines for a few times and it's all gone. So you have to manage it lifelong. You have to take precautions lifelong. And the other thing is no single discipline can solve NCDs alone. As we discussed in the previous story, that if we collaborate to take care of that patient from all of the discipline together, then only it can be treated properly. So now we'll discuss about the some of the challenges of NCDs. So first of all, let's discuss why we need the collaboration. Why NCD needs a collaboration? So it's very complex. It's dependent on lifestyle, genetics, environment, socio-economic factors. And the other thing is NCDs often occur with multiple risk factors that are hypertension, obesity, diabetes, and altogether. So a single person could have both diabetes and hypertension, and all of them can be linked together as well. And the most important, I will say, is the cancer, which I am working with. So I will say that how multidisciplinary collaboration helps in treating the cancer patient is sometimes we are having multidisciplinary team meetings where all the nurses, doctors, and all the oncologists, general surgeons, we all sit together, discuss the patients. There are the histopathologists, radiologists as well. So when a single patient is discussed among all of them, so they have a fixed opinion of a fixed treatment option, what is the best one for the patient. So that's why a patient is being treated in time and is getting the proper treatment what is required at that time. So that's the importance of multidisciplinary team collaboration. So why NCD demands collaboration? So globally, NCDs are the leading cause of death as discussed previously. So in Indonesia, I will say around 7 to 10%, 7 out of 10 deaths are due to NCDs as per a study conducted, and the economic burden is just staggering. And it's not just in the healthcare, it's in every industry we can see. So, but NCDs are simple conditions with simple solutions. So, as we can see that hypertension, this is not just the hypertension. It's not just about the blood pressure. It's about the lifestyle management, about the diet, about the genetics, and the person's stress level. Similarly, if we'll see about the diabetes, it's not just about the families, it's about culture, what food intake they are taking, their habits, their education, and the socio-economic barriers with them. And additionally, if we'll see about the cancer, it's not just the chemotherapy or radiotherapy. It's about the early detection of cancer, the support from the family, the support from the medical team, as well as how they are dealing post-cancer treatment, how they are being followed up post-cancer treatments. So that's why multidisciplinary collaboration matters in the case of NCDs. So next, I just wanted to focus on this, what the multidisciplinary team actually looks like. You can see it in the picture. So these all make the multidisciplinary team. And for now, we have just included all the community. We can include the policy makers, the health ministers as well, because they also play an important role in bringing any policy, any rule into the healthcare industry. So obviously, healthcare roles like doctors, nurses, nutritionists, psychologists, pharmacists, and midwife, they are the part of the multidisciplinary team. But extended role will involve the community workers, policymakers, and educators. Yeah, I would strongly emphasize on the educators, because when we are educating the children from a school level, if we'll see, and they are being educated about their diet, their lifestyle, and if school is implementing some yoga exercise, daily exercises, so we can reduce certain level of NCDs from childhood only. So the next is what multidisciplinary collaboration looks like in the practice. So we can see it in the 3 levels: the clinical collaborations, community, and policy systems. So clinical collaboration will be mostly with the doctors, nurses, nutritionists, midwife. So all of them working together for a single patient. And community involvement, as discussed, is the school, workplace. So for the workplace, we will say if a person is continuously doing work 9 to 5, 8 to 4, and is not taking proper rest, is not moving around, and is not having lunch in time, so it also impacts the patient's ability of getting the NCDs, and it enhances their chances of getting the NCDs. So local leaders reinforcing healthy behaviors. So there are local community workers who can just, if the person are illiterate, they can go from home to home, and maybe some group activities can be arranged for them to come, and they can educate them about NCDs, what they are, and how it can be prevented. So, and if we'll see at the policy and system support, guidelines So it basically means the healthcare guidelines which have been formed by the health ministers or the senior management level of the healthcare organizations. The funding. So if there is no proper funding, we won't be able to support the multidisciplinary collaboration. So proper funding is required for it because we are joining a lot of people together. So obviously we are trying to innovate something. So it requires a funding. Then insurance that make collaboration possible. So we will, in fact, the healthcare organization as well as the people are nowadays getting insured for their medical life. So it will also help in multidisciplinary collaboration, the practice level. So this is from silos to synergy. So what silos is, we have a habit of, in most of the countries, it's seen that patient goes to a doctor, just sees it and that's it. So most of the people are working in an individual level. So how we are going from the individual level to a group level, this matters in the case of this treating NCDs. For example, when nutrition education, screening, and nursing support are integrated, hypertension outcomes improve more significantly. So if nurses are checking regularly checking the blood pressure, they are taking follow-ups, and the screening programs have been organized for the NCDs detection. And there is a nutritionist who is providing the nutrition education to the patient. And if the patient is following everything, then we can significantly reduce the hypertension outcome, improve the hypertension outcome to a certain level. So, so what is the difference between the collaborative care and individual care? So individually, if we are creating more duplication, we are creating confusion because the patient comes to a doctor, he gets the medicine, he gets the advice, goes back, and he thinks that that doctor is not good because he is not getting better anymore. So he runs to another doctor. So he gives another medicine, and it all creates duplicates as well as confusion. And if we'll see in the collaborative care, so that patient is getting advice from everyone in that single unit. So that create a far better outcome as compared to the individual outcome. So in the collaborative care, the examples are like if we have a better referral system, if we have a better system like there are nurses, there are nutritionists, everyone in the same unit, and they are referred properly to whom they are needed. And there should be a system where should the patient go first, and there will be an electronic health record where the patient's record have been properly input, and then it has been transferred to the another doctors or nurses or where they are going next. So it will not create confusion among the healthcare workers, and it will not create any tiredness because the patient has to speak the same thing again and again. So the patient, wherever the patient is going next, they have all the information already with them. So building a comprehensive response to NCD. So how we are building it, how we will build it. So I will mostly focus on the 3 pillars of comprehensive responses. So which is prevention. The first most is prevention. So we are preventing so that we are not getting NCDs. So how it could be prevented is the education, the early education from the childhood itself, the lifestyle interventions, some minor changes in the lifestyle can help to prevent NCDs. So if we know that some of the NCDs run genetically, so if we know that our mom and dad have diabetes or hypertension, it's likely that you will get it in future. You can get it in future. So it's better to prevent it by making minor adjustments in your lifestyle. And early screening. So in some countries, the healthcare industry provide screening programs. If we are taking that program seriously and we are going for screening routinely, then we can prevent it to a certain level. Sorry. Then care and support. So multidisciplinary treatment teams or complementary therapies. So these are the things which will help the patient provide accurate care and support needed after care. So this is the thing after. So if we are following up a patient after providing the treatment, the patient automatically feels supported, that they are not leaving me alone. So I am being supported by them. Then integration and continuity. So connecting data, referrals, and follow-up so patient don't fall through the cracks. So that's what I discussed in the care and support as well. So falling through the cracks means patient is not feeling alone. So we have connected all the data, we have done the referrals properly, and we have then followed up. So if a patient is coming to me and I have referred him to another doctor or another therapies, so it's my duty to follow up with that patient that patient has received the proper treatment as I was expecting for him. So in that scenario, the patient will feel supported from both the sides. So it's significantly reduces the stress level and tiredness of the patient as well, and obviously the mental health situation. So there might be some challenges for the collaboration, which is always the case in any of the industry. When we are trying to implement something new, there might be some challenges, and similarly in the healthcare collaboration as well. So professional silos, that means some of the professions believe that they like to work alone. They have their private clinics. They don't want to collaborate. So managing them for the change can be a challenging situation. Then another thing could be resource limitation. As I discussed earlier, funding is the most important thing. So if we are not getting enough fund, we are limiting some of the resources which are required for dealing it. And the communication gap. So the communication gap is like we are referring some patient to somewhere and we haven't provided all the information which the other doctor requires. So that's called the communication gap, because we can't trust that the patient has told the same information to us and the patient has told the same information to that person, because the questions might differ. That's why it's necessary to communicate properly. And the cultural barriers. So in some of the countries, some of the cultures, there is a barrier we can say in case of the socio-economic things or some of the cultural thing, like patients are not properly literate, their culture prevents them for going outside. So these all are the barriers to collaboration. And how do we overcome these barriers? So there are challenges, but there are ways to overcome these as well. So the most important thing is education and training. So as we have discussed again and again, so education is the most important thing, because not every patient is educated to a level we are assuming. So it's our responsibility to help patient know what exactly it is. So when a patient comes, we have to tell them what he is having, what he or she is having, and why he or she is having that, and what he can do to prevent it to exacerbate the situations. And training. So, and the second theme is system redesigning. So if we see any faults in our system, which is preventing us to collaborate, we have to redesign the system. So that's totally up to the policymakers and the higher management level of the organization. And community engagement. So we can just engage the community level workers. We can create some of the campaigns for the poor patients, the middle class, poor lower class patients who are not properly literate, to help them understand what is it and why is it important. And lastly, the policy and leadership, which plays an important role in making a healthcare organization successful. So if we are having a proper policy and the leadership is very nice, then we can obviously manage the change in any of the organization. So I would take this webinar towards the future directions and how it will be in the future, and what's the call to action for this. So in the future, we know about the telemedicine and the digital health that will obviously helping us to collaborate and treat the patients more effectively so that we can have the better health outcomes. So digital health means there will be some information regarding the patient's health, which they can monitor by themselves. They can have telemedicine, so they don't have to go anywhere. They can just consult the doctors online, and they can get the nutritionist and the nurses, everyone, and the mental health treatment as well. Because mental health treatment requires, like, patient has to talk to them. They have to just release their anxiety and stress level. So it can be done digitally in the future. And I think it is now being done as well in some countries. Then patient empowerment, self-monitoring apps, community support groups. So nowadays we have seen that most of the smartphones and the watches, there are a lot of digital equipments which we are using nowadays, which are helping the patients to self-monitor their condition. So it's creating more awareness in the patients, like they are they are walking and they are counting the step, so that so we can say that they are quite active after wearing if they want to. So if they are getting proper education about how to improve it, they can do it by themselves and they can self-monitor it by the apps. Then policy support, funding, insurance coverage for prevention. So as I said, that insurance, most of the people are having the medical insurance for themselves to cover, and the funding for the supporting the policy which we are going to implement in future. So just to conclude with, a comprehensive responses to NCDs is not the work of one profession, one intervention, or one sector. It's when we combine research, clinical practice, education, and community action that we create lasting change. So, if from my presentation, the key takeaways which I want you to take is NCDs require multifactorial solutions. These are complex, but these are non-inevitable. We can deal with them. Multidisciplinary collaboration ensures prevention, care, and continuity. So firstly, we are trying to prevent it. If we are having it, we are caring about it. And then we are continuing to care about it to prevent it from exacerbating in the future. And challenges exist, but they can be overcome. As we discussed, there are certain challenges, but they could be overcome. Everyone has a role: healthcare providers, communities, policymakers, and patients. So each of the multidisciplinary team member plays an important role, including the patients, because nowadays it's very important to take patient consent, because we can't do any treatment and we can't take any decision if we are not taking the patient's consent. So it's very important for them. So tackling NCDs is like conducting an orchestra, I would say. Is one instrument alone cannot create harmony, but together they create a music. So it's the multidisciplinary team is like the instrument, the musical instrument, if we will compare with it. So I will say, if we want healthier communities, we must go together. And it's time to reflect for all of you. What one action can you take tomorrow to strengthen collaboration in your own work? So you all can think about this presentation and you can think what could be your action to strengthen the collaboration in your work. And lastly, my saying will be, if you want to go fast, go alone. But if you want to go very far, then go together. Thank you.
Okay. Okay. Thank you so much, Dr. Pallavi. It was an amazing presentation.
Thank you.
Okay, now we will continue to the discussion session. I need some rest. No? Okay, let's continue. Okay, we will give participants an opportunity to actively ask questions, either directly by giving a raise hand feature on your mobile phone or your PC, or through write your question on the chat box.
Sure.
Oh, okay. We have some question on the chat box. Okay. First from Arum Puspita. Okay, hello Miss Palavi. My name is Arum from Indonesia. I have question for you. Does student also have a role in order to deal with NCDs in UK? And what is their roles? You can answer the question now, please.
Yeah. So thank you, Adam, for the question. So yes, I would say that students can also play an important role in the collaboration because they are a medical student and they will be going to work in the hospital settings someday. So if we try to implement that in our student life itself, it will obviously help you to grow and work effectively within a team. So I would say that creating small scenarios, like creating small team meetings or team group presentations while you are a student will help how effectively a teamwork is done. And it will help you to work in the organization as well when you are going to work there. I hope that's clear.
Okay, thank you. Okay, Miss Arum Puspita, is it clear? You can give your feedback directly, or maybe you can answer your feedback on the chat box. Okay, let's move to the next question. It comes from Eva Noviana. Hello, Miss Palavija. My name is Eva from Indramayu. I have a question. The question is, compare with Indonesia, number of premature rates from NCDs is lower, only about 8%. Can you please explain what is the program that the UK have to prevent NCDs? Please.
Yeah. So thank you for the question. So in the UK, I would say is the NHS is working collaboratively now. So they have linked with the social care workers, they have linked with the private sectors, and they have a proper referral system, which is, and there are a lot of screening programs as well, like the premature rate. So the question is comparing with the Indonesia, the number of premature rate of NCDs. So yeah, I would say that it's because of the proper screening program. The people are highly educated about the prevention of the NCDs. There are a group of people educating them, the flyers, and there are regular monitoring of their NCD conditions. So I think because of this, the rate is lower in this country.
Okay, thank you. That is the answer for Miss Eva Noviana. You can give your feedback on the chat box. And Miss Arum have give you a feedback that was clear. Okay, let's move to the third question. It comes from Nelly Agustina. Okay, Nelly Agustina from Indonesia. I have a question. In what ways can policymakers, healthcare providers, and communities work together to sustain long-term collaboration and innovation in addressing NCDs?
So thank you for your question, Neil, Agustina. So I would say that policymakers do play an important role in collaboration because they are the person who will be making the policy. Healthcare providers are the person who will be accepting that change, and the communities. So they all work together in collaboration. So I would say that I can give the example from the England, they have a long-term NHS plan for the future. So they have discussed about the sustainability, the long-term plan, how they are going to collaborate effectively and improve the health outcomes. So I will say that policymakers are responsible for making the policy, but the healthcare providers are the one who will be accepting it. And there are the leaders as well. So management organizations, management level also plays an important role in sustaining it, because they are the people who will be dealing with the change, how to implement the change within the healthcare organization. So in this way, if a new policy is made, so they are the person who will be helping to implement it effectively, because there are some healthcare providers who will not accept the change, but the management team, it's their duty to manage that change effectively. So that's the role of the collaborative team. I hope that's fine.
Okay, so wonderful answer. Okay, Miss Nelly, you can give your feedback on the chat box. Okay, we still have some question. Okay, now the question from Vina Fuji. The question is, I truly appreciate with the information that you have shared. It was very insightful and engaging. I would like to ask, what are the key challenges and opportunity in building effective multidisciplinary collaboration for NCD's prevention and care? Please.
So yeah, so the key challenges, as I say, it's matching the person's behavior. So if I'll give example of the multidisciplinary team meeting which I am attending, so there are some situations when we are discussing the patients, but there are some arguments as well among the team members. So they are not one of the clinicians is making another decision and one of the clinician is making another decision. Both of them thinks that this is the best decision for the patient and this is the best decision for the patient. So that's where the arguments come. And so I would say that this is the most important challenge and opportunities in building effective multidisciplinary collaboration. So yeah, so I would say that to improve this challenge, I will say the people should keep the patient in the center. They should think of their health outcomes, and they should think that why they are working as a team here. So it's basically we are working for the patient's health outcome. So the arguments will be aside in that case, and that will be the effective health outcome. That will bring the effective health outcome by merging together of all that clinicians' decisions if they think together as a team, not as an individual.
Okay, thanks a lot. Before we read some question on the chat box, it has already the participant who raised hand wanna ask to you directly. Please, you can speak for Violin.
Yeah, sure. Okay, thank you. Good afternoon, Dr. Pallavi.
Good afternoon.
I have question for you. The question is, how can healthcare system ensure that integrate models of care remain patient-centered while balancing the diverse roles and expertise of different disciplines? Thank you.
Can you repeat it, please? That was a long one, sorry.
Okay. I repeat again. How can healthcare? Okay. How can healthcare system ensure that integrate models of care remain patient-centered while balancing the diverse roles and expertise of different disciplines?
So you are saying that they are collaborating the expertise from different disciplines.
Okay,
Yes.
let me explain clearly about her question is how can healthcare system ensure that integrated models can remain patient-centered. So the focus is about patient-centered by integrated models while balancing the diverse roles. So many multidiscipline, they have some roles like that. Yeah.
Yeah. Thank you. Thank you for your question, Varlin. So yeah, for the healthcare organization, I will say that there is a policy, there is a guideline, and I would say the main focus for every healthcare organization is the better health outcome for the patient and the patient-centered care. So to maintain this, there will be a guideline which is followed by every member of the teams, every discipline. So if we are referring to somewhere, as I said, we are following up, and that's the way we are just not leaving the patient alone. So, and if the other person is referring it to somewhere, it's his duty as well to follow him up. So I would say this is the collaborative method which is keeping the patient in center, and we are not leaving them alone. So as required, we are referring them for the better health outcomes.
Okay, thank you. Ms.
Thank
Foyle,
you.
is it clear or any feedback from you?
Is it clear? Thank you, Dr. Pallavi, for the
Thank
explanation.
you.
Okay, you're welcome, Violin. Thanks, Dr. Falvi. Okay, we still have a question on the chat box.
Sure.
It comes from Mr. Rido. Okay, I have a question. How is complementary therapy used to treat non-communicable disease in healthcare services in UK?
Thank you for your question. In UK, the complementary therapies are being used nowadays. So it's just, I would say the NHS has united with all of the sectors, the private sectors, the social care, the community centers, the primary health care. So it's just the referral system of the NHS is working very well. So if they think that the patient is, if we are thinking about the cancer patient, if we are thinking about the hypertension patient, if we think that we have prescribed enough drug, but the patient requires more of some of the therapies, which will be helpful for them to relieve pain or to relieve the stress, anxiety. So it's all depends on the referral system. So how we are referring them properly. So yeah, that's how it's managed in UK for the non-communicable diseases. So it's all based on the referral system.
Okay, thank you.
Thank you.
Mr. Rido, any feedback from you? And we have some feedbacks from some participant who give you a question, and all of them said that it was clear. Okay. By the way, may I ask to you?
Yeah, sure.
Yeah. Okay. I want to know about what is the most complementary therapy in your hospital, because your hospital concern in cancer. Yeah, because the number of patients who suffered cancer in our country is almost high, and it becomes the causes of our mortality and morbidity.
Yeah.
That's it.
Thank you for your question. So for cancer patients in our country, I would say that there is a plan for after treatment, post-treatment care of the patients. So that is, as we all know that some of the cancer patients are mostly in the later stage of their life. So there is a Macmillan support group of the nurses who are dealing with the end of life care. So they are just following them up, they are supporting them with their day-to-day life activities, their pain, helping to reduce their pain levels, and helping to listen what they feel, how they feel about it, and encouraging their family members to be with them so that their stress level is little bit reduced. So I would say that it's mostly the Macmillan support group of the nurses who are dealing with the cancer patients, the end of life support group.
Okay, thanks a lot. Yeah.
Thank you.
Okay, because the time has over, maybe we will move to the end of this session.
Sure.
Okay, thanks a lot
Thank
for
you.
for Dr. Palapi. Let me summarize the discussion. It is
Sure.
clear that no single discipline or sector can tackle the growing burden of NCDs alone. The insight we have shared highlights the importance of working together toward a more integrated and patient-centered approach. By strengthening collaboration, we not only improve the efficiency and quality of care, but also address the broader determinant of health and shape outcomes. Building an integrated model means bridging gaps, aligning strategies, and fostering innovation across disciplines. Okay, ladies and gentlemen, we have a wonderful two presentation from two very inspiring speakers. Once again, we would like to thank to Nurse Rido and Dr. Palavi for the knowledge that have you delivered. We hope that the insight you have gave can strengthen our thinking concept so that we can apply complementary therapy by involving various scientific disciplines and multi-sectors. Okay, ladies and gentlemen, the next event will be given certificates to the speakers. Okay, for the first certificate, for Nurse Rido will be given by the head of the Indramayu College of Health Science to Mr. Rianto, please.
Okay, thank you, Nurse Wiwi. Thanks very much for Dr. Palavi and Nurse Rido for that great presentation. We really appreciate you coming to speak with us. Here is a certificate to say that your thank you very much.
Thank you. Thank you for having me with this webinar.
Okay, Miss.
Yeah. Okay. We have watched the giving certificate that has delivered by the chairman of Indramayu College of Health Science, both for Dr. Palavi and for Nurse Rido. Once again, we want to say thank you because we have so many information and many knowledge from you. Okay, because it is the end of our discussion, I will give the time back to Master of Ceremony. Thank you.
Thank you.
Thank you very much, Nurse Wiwi Nuraini MK. Ladies and gentlemen, that concludes session 4 of our webinar. We sincerely thank Nurse Wiwi Nuraini MK for skillfully guiding the session and all our speakers for their informative presentation. We also appreciate the active participation and engagement of all attendees, which made this session successful and meaningful. On behalf of the organizing committee, we hope you gain valuable knowledge and insight. Thank you for our speakers and our moderators who lead the discussions. Ladies and gentlemen, that's all for today. I'm Rani Fitriani as the Master of Ceremony. Thank you very much, and I apologize profusely if any words that are less pleasing to the audience here. Let us close the International Webinar 2025 Comprehensive Responses to Non-Communicable Disease, the role of multidisciplinary collaboration in prevention and care. Thank you and see you in the next time. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Warahmatullahi
Thanks a
wabarakatuh.
lot,
Yes,
Mas
selesai.
Rido, Dr.
Thank
Falavi.
you.
Thank
Thank
you.
you.
Oh yeah, Mrs. Nanda, thanks a lot. Yeah. See you in the next year in the same agenda, maybe offline. Okay. You can leave from this Zoom. Okay. Thanks a lot. Bye.
Assalamualaikum warahmatullahi wabarakatuh. Greetings to all of us. The Honorable Chairman of Yayasan Indra Husada, Mr. Nur Rahim Satria Nugraha Eskom. The Honorable Chairman of Stikes Indramayu, Mr. Nersrianto MK. The Honorable Director Boromarajonani College of Nursing Saraburi, Thailand. The honorable speakers and also the audience and webinar participants. Let's say thanks to God who has been giving us blessing and mercy so that we can gather in this event without any difficulties. Amen. Ladies and gentlemen, here I am Andini Sulistiani as the Master of Ceremony will guide this International Webinar 2025 with a comprehensive response to non-communicable disease, the role of multidisciplinary collaboration in prevention and care. Before starting our agenda, let me explain the agenda schedule of this webinar. First agenda is opening. Second agenda is speech by the Director Boromarajonani College of Nursing Saraburi, Thailand. Third agenda is a speech, the explanation from our speakers. And the last agenda is closing. All blessed audience, the first agenda is opening. Let's start this agenda by saying Basmalah together. Bismillah. The second agenda is speech by the Director Boromarajonani College of Nursing Saraburi, Thailand. For Assistant Professor Dr. Wilayporn Kamwong, time and screen is yours.
Okay. Selamat pagi. Good morning, everyone. And dear the chairman of the Stikes, Indramayu, Rianto, distinguished guests, faculty members, and students from both Indonesia and Thailand. It is my great pleasure to join your international webinar as co-host by the Stikes Indramayu and Boromarajonani College of Nursing, Saraburi, Thailand. This event reflects our shared commitments to tackling the global health challenge, especially about non-communicable disease or NCDs. As everyone knows that NCD like heart disease, diabetes, hypertension, or cancer, or even stroke, account for actually over 70% of death worldwide and are the leading cause of illness in both countries, like in Indonesia and also in Thailand. While the burden is heavy and many NCDs are actually preventable and also manageable with the appropriate approach, one of the most effective strategy, like on our topics that we have to work as collaboration. We cannot work alone to solve this problem. For example, in Thailand, we have a primary care team that work with nurses in the community. And also we have the health volunteer. We will go visit the patient homes or the people home to manage and prevent the chronic diseases. And also in Indonesia, you also have like, I believe that they call post-bindu program at your community health center, involve multidisciplinary team, offering screening and counseling for NCD patients. These are the, I think, is excellent model of how team-based care can improve access and also outcomes. Of course, we face these challenges, but we have limited resources. However, to tackling or to solve these challenges, we have to work together with other team, I mean healthcare team. So the partnership between us, STICKES Indramayu and Boromarajonani College of Nursing Saraburi is very meaningful for step forward to cooperation between us to share experience and also this solution. We can contribute the stronger responses not only in our country but across the region. In closing, let's remember that NCDs or non-communicable diseases are not just a medical challenge, they are a human challenge, and they require a united response across professions and borders. Thank you to all organizers, speakers, faculty, and students for your dedication and also participation in this international webinar. Thank you. ขอบคุณค่ะ All right.
Thank you very much for Assistant Professor Dr. Wilaypon Kamwong for the next agenda and the main agenda which we are waiting for. Explanation from our speakers, lecturers, and students from Indonesia and Thailand. The next agenda will be guided by Nurse Wiwi Nuraini MCAP. For Nurse Wiwi Nuraini MCAP, time and screen is yours.
Thank you to the Master of Ceremony who has authorized me to guide the discussion at this webinar. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
The Honorable ladies and gentlemen, good morning everybody.
Morning.
Morning. the opportunity to guide the discussion in this webinar. Ladies and gentlemen, non-communicable disease remain a leading cause of death and disability worldwide. In this context, interdisciplinary collaboration is crucial. Doctors, nurses, public health workers, policymakers, community leaders, and even sectors outside of health must work together to design and implement effective strategies. By fostering multidisciplinary teamwork, we can bridge gaps in service delivery, strengthen patient-centered care, and promote healthier population. Today, we will explore how such collaboration can transform the way we respond to non-communicable disease with a focus on shared responsibility and sustainability impact. I invite you all to actively engage, exchange perspectives, and contribute to the discussion on non-communicable disease prevention and treatment. Before we continue to the presentation session, let me introduce our speakers for today. First, Dr. Siriwan Tumchea. Hello, Siriwan.
Hi, good morning, everyone.
Yeah, good morning. Sawadika.
สวัสดีค่ะ
Yeah. And the second speaker is Nurse Sophie Octaviani, PhD. Good morning.
Good morning, Mrs. Wiwinaraini.
Ya, selamat pagi.
Selamat pagi, sawadika.
Yeah, thank you so much. Ladies and gentlemen, I will explain the rule of this session. Each speaker will have 45 minutes for the presentation. Please keep your microphone mute while the presentation. Then we will give 15 minutes for question and answer. You can ask directly or by chat box. Okay, let's start to the first topic. First presentation will be delivered by Dr. Siriwan, but I will introduce about herself. She is a Deputy Director of Research and Academic Services in Boromarajonani College of Nursing, Saraburi, Thailand. She is interested in teenage pregnancy and non-communicable disease in the community. And for today, she will deliver a presentation about integrating telenursing and the PBRA model as a multidisciplinary approach to non-communicable disease prevention and management in primary care Thailand. Please welcome Dr. Siriwan. It's your time.
Thank you so much, Vivian, and everyone. Good morning again. And my name is Siriwan Tumchea, and I serve as the Deputy Director of Research and Academic Service at Boromarajonani College of Nursing, Saraburi, Faculty of Nursing, Boromarajonani Institute. Today, I'm proud to present from my experience with you in the topic of how telenursing integrate primary health care for multidisciplinary approach to NCD prevention and management in primary care. First, I would like to share my slide. As is known that NCD is high prevalent and the global death globally according to the WHO in 2024 data. The top 4 of NCD is the cardiovascular disease, cancer, diabetes, and chronic respiratory disease. And right now in Thailand, the NCD has impact both economic and current healthcare system, because the healthcare system in this era face multiple challenges, such as the limited healthcare workforce or the geographic barrier that prevent the patient from accessing care, or the rising costs that make treatment unaffordable for many fragment care delivery, and the poor continuing care. So the PBRI take the role as the Institute of Health Science, that we have the PBRI model, that is an integrated of higher education mission into the development of the primary care system in Thailand. This model to enhance the quality of life for people in the community through a primary healthcare approach. For example, we have the screening through surveillance and the prevention of communicable and non-communicable chronic disease using the 7-color traffic ping pong tool. And we have 3 E's, 3 R's activity. This is the principle related to health promotion, disease prevention, medical treatment, and rehabilitation to prevent complications for the NCD. And in addition, for this model, we have a community-based model that grounded in learning, that emphasize the local wisdom, that integrated disciplinary integration and partnership building, and active community participation for overall community well-being. And the last one, this model has a collaboration with other sectors, such as religious and educational institute and sector. So for So from the PBRI model, we use this model to implement for prevention the NCD in the community through the telenursing. So I would like to present how telenursing integrates primary health care for primary care in PBRI model. This model consists of 3 sectors. The first one is primary health care for PC, that consists of 5 C in primary care, such as first contact, comprehensive, coordination, continuing care, patient center, and community-based education. And the telenursing is the use of telecommunication technology to deliver nursing service and conduct nursing practice across distance. So the PBRI is the Institute in Health Science, so that we have the role to develop and students are trained to manage a wide range of common conditions and provide comprehensive service. And the students are trained to work coordinately with people in community and health profession. And the students are trained to care for people through their lifespan, from antenatal care to the end of life of care. So for this section, we use the telenursing in for control or for help educate the people who have the NCD, and the student trained to care for person in holistic approach and care for the people as a whole community. What about the definition of PHC or primary health care. The primary health care is the essential healthcare based on scientific, sound, and social acceptable method and technology. The key principle of the PHC is consists of universal coverage, because in Thailand we have the policy, the universal coverage for people, all the people in Thailand. This can use this policy, and the second key principle is the people center. This approach have to focus on individual and community need for healthcare and comprehensive care. It means that this approach cover the prevention, promotion, treatment, and rehabilitation. And in addition, in the community, we have work coordinate care. So we have integrated across level and sector. That means we integrated the multidisciplinary care team for the care the person in the community. And in addition, the last is the quality and safety. We have the evidence-based and safe practice for the PHC in Thailand. And for the PHC component for NCD, what is the important component? It consists of the health promotion and disease prevention. For this health promotion and disease prevention, we use the ping pong, 7 ping pong color for screening, and for prevention, the NCD in the people, and early detection and screening with 7 color ping pong, and treatment and management, and rehabilitation and palliative care. This is the component in the PHC for NCD in Thailand. But for the component of telenursing, the remote monitoring, because this approach, the telenursing is used for the rural area or the place that distant from the health center. We use telenursing, and the useful of telenursing for healthcare and patient education, because we are the nurse. So the nurse role is the patient education through self-management or lifestyle modification of the patient in the NCD up to the condition of them. And coordination is mean that the communication with healthcare team, we have the doctor, the nutrition, or the pharmacist work together in this approach. And clinical assessment is mean that the virtual consultation between the healthcare team and the NCD patient and the follow-up care. Technology platform for this time, we use the mobile health application used in telenursing. Multidisciplinary care team approach. What does it mean? It means the team member who work together and coordination to take care of the patient or to treat the patient together. It consists of the primary care physician. We have the physician we call หมอครอบครัว in Thailand to diagnosis, treatment, or decision for treatment the people who have NCD. Nurse is taking care, who have a care coordination for the patient education and monitoring. Pharmacist is take a role as the medication management or adherence counseling. Nutritionist is dietary counseling and planning. Social worker who work as the psychosocial support or research coordination. And community health worker is local support and advocate it seems like the volunteer of us in the care team. And specialists if needed, such as the cardiologist or endocrinologist. The collaborative care model benefit. Why this? We use this technique to approach the NCD people in Thailand because the comprehensive assessment and care planning improve patient outcome, especially in the patient with NCD, enhance care coordination, better resource utilization, and reduce healthcare costs. Integrated PBRI model and telenursing with PHC. The first one is identify the target population. We use the ping pong 7 color to screen the patient who have the indication such as in my community we use ping pong 7 color to screen the patient who have the sugar level uncontrolled. So in this slide, I show the DM control patient who have participated in my approach. And in addition, for the identified target population, we used to consider about the geographical and some people who have the limitation and require frequency of monitoring. So we use these key point for the identify the population. And so network building, we have to MOU such as us for the building network to establish partnership between healthcare facility in the community to connect urban specialty with rural primary care integrated community health worker and technology infrastructure. In Thailand, we have telemedicine is the big structure for treatment and take care the people. But for the PBRI model, we is the institute in health side so that we use the mobile health such as the technology infrastructure used in telenursing. And staff and training, we train the teacher and the student use the mobile health, and in addition the nurse in the health station use mobile health for health education for the people. And guideline and protocol standard care pathway. In this approach, we use 3 E's and 3 R's activity. This is the principle for control and to promote and prevention NCD people. And resource allocation, we have human resource planning, and in addition, we have patients who are interested in the approach and volunteer to in this approach. And in addition, the last is the patient satisfaction and patient engagement in this program. So if we consider the PBRI model and telenursing with PHC, we found that this model benefit for the patient who have NCD and need approach from the healthcare team with multidisciplinary care team from the through the technology that is suitable for this era is the digital technology era. For example, I would like to show my experience from the community that I work with the student nurse from Boromarajonani College of Nursing Saraburi. We use telenursing system on diabetic patient care in primary care services according to the concept of PPRI model and 5C. A case study from health station at ลำพญากลางอำเภอมวกเหล็กจังหวัดสระบุรี So integrate telenursing and the PBRI model in action. We use the first contact with line OA and line group. This step is the important to for the patient engagement in this approach. If they not have mobile phone or not, I cannot use mobile phone, is not available and is not okay for them. So for this approach, it might be a barrier for the elderly or the who not have the technology and to use this technique. So for the comprehensive, this technique we use for prevention and promotion and treatment through line, such as in this picture, you can see that in my line application, we have the communication through line OA and line group for consultation and real-time chat for the communication and health education, and including to daily plan from the patient who have to control with the sugar level in blood vessel and the continuing care. This is approach use pre-hospital, in hospital and hospital or health station through line OA. And for the collaboration, we have nutritionist. This picture show her in the white shirt who have help educate for the nutrition in the DM patient, and patient center is DM patient. And after we use this technique, we found that the patient can be control the sugar level from the first time they engage for 25 diabetes patient. After finish this approach, the patient can control the sugar level 23 about 92% for success for this approach. Why we use this telenursing to control the sugar level? Because the people or the participant in this community have the they work as the milker, you know, the milker. They have the milker, and in the early morning they have to work. And for the medicine in the first time they cannot take in the right way, so that they cannot control the sugar level. So when after we use this technique, they can control. The next feature, I would like to expand the use of telenursing to line group and line OA to provide knowledge following the 3Es and 3S principle that initiate with the benefit and variety of recipients, including the general public people or the people who at least group. So if we have to help educate the people before they get NCD, so we can decrease the patient and we can decrease the cost for treatment the people in this group. So these benefit for the people and the family, and we use this ping pong color level according to the PBRI model to screening and the approach of us. So this is the experience just is the first step. It's not it need to research and develop the protocol and the intervention in the future. But I think this is the very interesting for the student nurse and the people who not have NCD to prevention and to promotion health of them. Thank you so much for let me share this experience. Thank you.
Okay, thank you so much, everyone. It's so briefly presentation. Thanks a lot. We can now about how telenursing implemented in your college. And actually, it's so inspire us. I hope our student can implement it also. Okay, as I said before, after you give your presentation, we will move to a discussion session. And for this session, I will give chance to the participants. You feel free if you want to ask directly to Siri One, maybe want to say hello and then make some speaking with you, or if you want to ask by chat box, we provide it, so feel free for the participant. Okay, let me check. Okay. By the way, while we waiting the question from the participant, wait a moment. I heard some sound. Maybe the question has ready, or some participant have raised hand. Belum ya? Okay. While we waiting
Sorry,
about
sorry, ma'am.
Oh yeah. Please
Okay.
welcome. Introduce yourself.
Okay, my name is Rudiansa, but I want to show you I can raise hand on the Zoom application. Why?
Okay, we will check to the operator. Please check so the
Baik.
participant can use raise hand feature.
Baik. Can I ask?
Please.
Yes.
Baik. Thank you for your time. This morning, the lecture material was very interesting. I have a question about regarding funding allocation to receive universal health coverage. Is all funding borne by the state or by the community? But in Indonesia, the government cover the poor community, while the wealthy pay independently. How about Thailand? Thank you.
In Thailand, the health coverage is supported by the government. We have three types for health. I mean that the health coverage is for the people who have Thai nationality. The first one. The second one is the Thai nationality who work and pay the money to, such as we call co-pay for health of them. And the last is the government support for the the people who work with the government. Yes, we have 3 level of the corporate health corporate in Thailand. This is I answer your question.
Okay. Yes, but I have the last question.
What
Okay.
what about the last question? Again,
Okay.
please.
Baik. How can we build partnership between stakeholder to support this program? Because in Indonesia it's apa sulit ya sulit itu difficult to building a partnership between all stakeholder.
In Thailand we have health volunteer in every community. We have health volunteer to work instead or serve as the first step to take care the people. So it's simple in Thailand to have the stakeholder engagement with health volunteer to give the information or to recruit them for this health care provider. I mean team healthcare provider work is simple because we have health volunteer in the community.
Thank you very much for your answer.
Thank you for your question
Okay,
too.
is it okay? Is it clear, Mr. Rudy?
Yes, thank you.
Okay, you're welcome. Okay, thanks, Siriwan, for your answer. And then we invite for the second question. You can raise hand on the feature. Or okay. Please.
So thank you very much, Dr. Sirwan, from the very impressive explanation about the that has established in your university. So one thing that make me interested is, does the applications is also applicable if we want to develop in the other country, like the others middle income country like Indonesia? So I asked about the probability the applications has been established in the other country like Indonesia. However, in Indonesia, it is not common to use Line. We usually using WhatsApp. And I also asking about, does this application also modifiable? So can we modify the application? Because I think it's if we can have the research together between Indonesia.
Yes, I think it's really interesting for your question. Actually, in Thailand, we have telemedicine used in the hospital. All of the hospital in Thailand use telemedicine, but we are the institute. We are in the institute in the health science, so we don't have the telemedicine, just the big structure for the student to learn, so that we apply from the Line application for the student to learn to approach the patient through Line. This is point is for me to develop the approach through telenursing. So in Thailand, the Line application have popular use. If you want to develop the application, it can, because I have experience develop the application for health education for the teenage pregnancy to prevent the repeated pregnancy in the adolescent mother with the family support. I have experience, but I am a nurse, so I cannot developed by myself. So that we have to share the idea with the engineering, computer, or the others science to help us for solve the problem that we interested through the mobile health or to the telenursing. Yes, you can. And this is the first step for the research in the Indonesia, and the student can learn with us. Yes. Okay.
Yeah, thank you very much.
Thank
This is
you.
interesting. So in the further, I hope we can conduct research collaboration using this application.
Okay, I am proud to work with you. Thank you.
Okay, thank you so much, Mrs. Sophie and Siriwan. Yeah, because talk about collaboration not only between same profession but also a multi-sector. Yeah, as you say about machine or maybe electronic and others
Yes.
sectors like that.
Yes.
Okay, thanks a lot. Okay, and we invite for the third participant. Maybe there are still questions for you. Okay, we will still have one chance more. Okay. Or maybe you can ask directly. Okay. See. Okay. Sriwan, maybe while we waiting the question for the participant, I am so interested too with your project, your research. How we can integrated this project in the curriculum. I mean, in my country, there is rules that we have to integrate it between research and then community service and also of the education in the class. So, are you integrated the activity of the student in the curriculum so they will get so many advantage like that? Thanks.
In Thailand, we have intra-curriculum and extra-curriculum activity for the student nurse. Intra-curriculum is mean that the student nurse have to learn from uh the course. I mean the main course. So if we want to develop the student nurse, it seems like to have extracurricular activity to serve the competency of the student nurse. Just like that in our college do that. I think this is the way that we do. I'm not sure for the answer that you want to know. Is it okay?
Okay, yeah, I know. I get your point. Thanks.
We have a member. We have faculty member attend our webinar. Maybe they can share the knowledge from our country.
Okay, thanks. Okay. Their participant will give you a question. Please speak up.
Hello, I want to ask about what is the role of students to develop and utilizing the application?
What again, please?
What is the role of students to develop and utilizing the application?
Okay, I have the student in our college to do the application in the research subject. They can develop in the research subject and to test the application from this subject. Is it okay? Yes.
Okay, thanks. Is it clear, Delia?
Yes, thank you for the answer.
Okay, so all people have a rule, yeah. Also for the students. Okay, Siriwan, I think because the time has over for this session. Thank you so much, yeah, for your presentation. Or maybe you will have some statement closing.
No, thank you so much for attention and have a question. And I great to be here and to proud to present from my experience. And we hope that we have the next step for the research collaboration between of us. Thank you so much for this the international webinar to give me chance for sharing. Thank you.
Yeah, you're welcome, Siriwan. By the way, please, would you like to still join with us until the end of the second speaker? Because after that, we will give you a certificate. Is it okay?
Yes, thank you so much. Yes.
Okay, thank you. Okay, ladies and gentlemen, let me summarize the discussion. Multidisciplinary teams have their respective roles, and all disciplines are important. Collaboration, especially in primary healthcare, can improve non-communicable disease prevention and health promotion. Okay, now let's continue to the second speakers. The presentation will be delivered by Nurse Sophie Octaviani, PhD. Hello, Miss Sophie.
Hello, Miss Is it, does my voice clear? Yeah.
Okay. Before we give you a chance to present your material, let me introduce you to the participant. Mrs. Sophie is graduated her Bachelor of Nursing and Nursing profession in General Sudirman University. Then she continued her master and doctoral in Mie University, Japan. And she has several research and publication related non-communicable disease among children and adolescents. And for today, she will present the topic preventive approach to non-communicable disease among children and adolescents. Okay, Mrs. Sophie, are you ready? Yeah.
I'm ready.
Okay, the time is yours, please.
Thank you very much. Good morning, everyone from Indonesia and from the Thailand University. In today's topics, I would like to elaborate the topic about the preventive approach to the non-communicable disease among children and adolescents. So these are some topics that I want to elaborate today. We are going to discuss starting from the global trends of non-communicable disease. And this is the map of the prevalence of non-communicable disease globally. So the darker colors indicate the highest prevalence from each country. So as we can see here, we compare three different country levels as the representative from the meeting, today and tomorrow's meeting. It is come as the representative of the high income country has the lower prevalence compared to the other middle income country like Indonesia and Thailand, which is it's only about 85,000 prevalence per 100,000 people. And in Indonesia and Thailand, we have a similar number. And this is the observed and projected trends for the risk premature mortality from the non-communicable disease, which is it is grouping by the WHO regions and by the World Bank income groups from the high until lower middle income country. Globally, for most of the country, we create the positive progress of the trends of the premature mortality, which is the number has decreased significantly between 2000 and 2020, except Southeast Asian regions, and steadily it is where the Indonesia and Thailand live in. Middle Eastern is the only region which is it has the acceleration from the SDGs era, and it declined by 1.2% from 2000 and 2015. And in the following year, in 2000 2.8. This it seems which is the Eastern Mediterranean kids disease, cancer, diabetes, chronic respiratory disease between age 30 and 70. So again, we compare to 4 different countries representative from the today's meeting. It is Indonesia, Thailand, UK, and Japan. So the WHO is counting the probability of dying is focusing only for groups. It is because these 4 groups are disease is account for about 80% of all premature non-communicable deaths globally. So we can see here, Indonesia is leading country in the most worst probability from dying from any non-communicable disease by 21.9%. And it is followed by Thailand, UK, and Japan. What we see here is there is a huge gap about the preference between the high and lower middle income countries, represented by the Indonesia and Thailand, and then the high income country is presented by the UK and Japan. So it is because the WHO reported that amongst all of the deaths in 2025, 7
Okay, wait a moment. Mrs. Sophie are out from the Zoom. Okay, take a moment. Yeah. And if the participant, as I said before, if the participant want to ask about the preventing a non-communicable disease in adolescents or in children, please feel free to write
on the chat box. Yeah, or maybe if the participant have an experience to carrying a patient in adolescents or in children, you can share with us. So the participant not only ask about the topic, what has delivered by the speaker, but you also can share what you have get, so we can know each other about the new experience or a new education. And as an information, after these sessions, we will continue to the next session, and the speakers will be delivered from the student. Collaboration between Indonesia students from SIKAS Indramayu, and then from BNC student from Thailand. And they will share about their experience, how to caring or how to prevent a non-communicable disease based on their culture in their country. And then how the unique of the patient that that they meet when they give deliver the caring. Okay. Yeah, I think Mrs. Sophie has already joined with us. Please continue.
Sorry, we have technical problems with the internet. So the next, there is a huge gap between the high and lower middle income country. So I think this is a big problem from the middle income country, including Indonesia and Thailand, to deal with this problem. This is the relationship between the risk factor provide this evidence is come from the systematic review and meta-analysis about some associated factor with the non-communicable disease, like from the unhealthy diet until the high numbers of the alcohol consumption. In this evidence of also provide the additional context information about how the further potential relationships has happened between the risk factor itself and for the non-communicable disease itself. For example, in here, we can see the physical activity and also unhealthy diet, somehow it's associated with the obesity. And the obesity itself will be caused as the main problem from the high blood pressure. And the risk factor here is associated with the stroke, and as the stroke will be correlated with the Alzheimer's disease. So if we are talking about the non-communicable disease, it is a very complicated and it is very sophisticated, which is it includes many risk factors and it also creates many diseases. And these are some behavioral risk factors that informed by the WHO in 2021. Mostly the non-communicable disease and this unhealthy behavior will be increase the risk of the metabolic risk factor, which is it includes the rise blood pressure, overweight or obesity, high blood glucose level, and abnormal blood lipids. And the leading metabolic risk factor of NCDs is the high blood pressure, which is it is about 25%. It's contribute to the non-communicable disease, and or reason we are focusing on the early prevention among children. So placing children at the heart of the non-communicable disease is a very essential. It is because over 2.1 billion children and adolescents under age 20 years are affected by the non-communicable disease or exposed to the relevant risk factor. And then the roots of there are some key facts that it is about 81% of adolescents is not engaged in the sufficient physical activity, and it is about 150 million tobacco use among adolescents, and there are about 391 million children and adolescents living with overweight and obesity. And over 90% of the children under 50 years are with the toxic air daily. So, and up to the 80% of the premature heart disease is actually preventable. So I think it is a very good point if we want to start the prevention program from non-communicable disease, start from the children and adolescents. And this is the evidence-based interrogation of the childhood obesity findings from the research, my personal research into the non-communicable disease prevention initiative. This is the reason why finally I interested in study about overweight and obesity in Indonesia, because it brings some consequences. Like first, child overweight and obesity will be increased risk of the adult mortality rate, which is for those children who's living in the overweight and obesity condition will increase their risk to become mortality risk 3 times higher compared with the normal students. The overweight and obesity also causes some like anxiety, depressions, high blood pressure, obstructive sleep disorder breathing, and recent study it also associated with the severity of COVID-19. And majority study conclude that overweight and obesity among children will be continue into the adult obesity. And this is the trend of the global obesity in the world. So actually, recently, in almost all countries, we are facing the double burden of malnutrition, which the overweight and underweight has happened at the same time and in the same country level. However, compared with the undernutrition, it's represented with the thinness here, which is it has the number of the thinness has decreased significantly over in the last 2 decades. The prevalence of obesity and overweight has increased significantly. And surprisingly, Indonesia, as representative of the middle income country, the risk of the increased prevalence is higher compared to the other income country. Like it's 5 times higher for the obesity and it's 3 times higher for the overweight. And this is the my personal roadmap study for the child obesity. Starting in 2022, I study about the factor child obesity in Indonesia. And after that, I quantifying the geographic variation and geographical interdependency between data in order to detect cluster of overweight and obesity in Indonesia. And recently, we are still studying about the school food environment and how does the school food environment is associated with the overweight and obesity in Indonesia. And this is the result of my study in 2022. The study itself, it's gathered from the Indonesia Family Life Survey. It is a longitudinal study which is conducted by the RAND organizations from United States. We analyzed among 6,700 students aged 6 until 12 years old, and we found some associated factor which is associated with the child overweight and obesity. Interestingly, we found it that for those children, for the parents' perception is somehow associated with the lower risk of overweight and obesity in Indonesia. So the perception here is the questioners asking the participants about how adequate your children to intake the food or to consume the food daily. And the questioners respond with it is more than adequate, it is just than adequate, and it is less than adequate. And interestingly, for those parents thinking that the food consumption is less than adequate, somehow it's become the preventive factor of the child overweight and obesity. In order to elaborate about this evidence, it is important to us to understanding that the way in which parents perceive their children's diet quality is a very important to ensuring a healthy diet for the optimal development and disease prevention. However, a common perception in Indonesia, there is a common thinking among the parents. The parents will be thinking that the children who become overweight is somehow is a very healthy and a very cute. So how this perception will finally elaborate the result of our study is maybe the way how the parents respond from the questioners from our study. Parents thinking that the children is not overweight or the children is in a normal weight, the parent will thinking that this food consumption among these children is less than adequate because the common perception is overweight is healthy and very cute. So those children who were in a normal condition, parents may be thinking that yeah, the impact of this consumption of this food is will be less than adequate. So because of our study is not interfacial causal, our study is a cross-sectional study. So finally, in the analysis called analysis, the analysis will be treated that less than adequate will become the preventive factor of the child overweight and obesity. And the other result of this study also thinking that for those father who are overweight and obesity also a risk for being overweight and obesity among children. And it's similar with the other study in a systematic review in a meta-analysis in high-income country, which is the child obesity was associated with the overweight or obesity among fathers. So maybe all the participants here asking why it's just happening in the father's nutritional status, why the mother's nutritional status is not associated with the children's and overweight and obesity. So we elaborate about by using the social learning theory approach. The social learning theory approach, it is elaborates about how the children imitate the other behavior through the process called the reproduction. So in Indonesia, simply the social learning theory is about what children see, then it is what the children do. Predominantly in Indonesia, Indonesian father is a very more permissive than the mothers. So the permissive parenting in somehow we will create more opportunity to replicate their father obesity promising behavior. So in other words, the children will be see more the father's obesity promoting behavior more frequently compared to the mother. And there is an interesting fact also in the Japanese father, it's expected to be an imitation model for the children. And then the other results of this study also somehow become some ethnicity in Indonesia will be increase the risk for being overweight and obesity. So we use this evidence to elaborate our finding. We found that the characteristic of Chinese mother in China, which is they are frequently use sweet and desserts as a reward for the children, and it will create the greater consumption of sweet food that will be contribute to the increase of overweight and obesity. Meanwhile, becoming Javanese also will increase the risk of overweight and obesity because for those people living in the Java Islands, particularly in the Central Java province, East Java province, and the Yogyakarta, it is consume more sweet food per day compared to the Sundanese people did in West Java province. And also, if you come to the province of Yogyakarta, the cuisine of the Central Java and Yogyakarta is a very sweet. So this is the reason behind why the Javanese people it's taking more risks for being overweight and obesity compared to the Sundanese people. Another research from the spatial cluster of child obesity and overweight, which is we gather data from the Indonesia Basic Health Survey. We found it that there are 20 clusters of overweight was found in Indonesia and 36 clusters of obesity were found in Indonesia. It is clearly, as you can see here, mostly the cluster will happen in the western island of Indonesia, and then it is less commonly happen in the eastern island of eastern part of Indonesia. We use the socio-economic approach in order to elaborate about this finding. The study found that the Human Development Index somehow in the western part of Indonesia is higher compared to the eastern part of Indonesia. And also, the poverty rates in western of Indonesia is lower than the poverty rate in the eastern part of Indonesia. So the gaps of the economics between western and eastern part of Indonesia will be emerged as the one of the potential causes of overweight and obesity cluster was found in Indonesia. The other reason is through the rapid urbanization, which is the rapid urbanization is higher, mostly happen in the western part of Indonesia, and especially what happens commonly in the island of the Java. So residing in an urban island increases the risk of childhood overweight and obesity in the middle income country. And however, one interesting finding about my result is Indramayu district, where the Stikas Indramayu located, it is basically a rural area, not an urban area, but we detected two clusters or both cluster of overweight and obesity in this study. So finally, we utilize this result of this study to conduct further study, which is we conduct the food environment conducted in Indramayu district. And these are the literature review that we found about the child obesity, which is we found a research gap between the high and middle income country. Basically, both in a high and lower middle income country, there are a similar factor that contribute to the overweight and obesity, like from the pre and postnatal factor, individual factor, familial factor, socio-economic factor. However, compared with the high income country, which is there are some study conduct about how the environment factors contribute to the overweight and obesity. There's only few study about the environmental factors. So in the future, we need more evidence about the food environment, how it is finally associated with the child obesity in the middle income country, especially in Indonesia. So this is the conceptual framework that we use in order to describe about food environment in Indramayu district. Actually, if you're Googling in the internet, there are some food environment framework provided, but finally we utilize this framework because this is the only framework that's created in the lower middle income country. So we finally using this framework. So what is the food framework actually describe about? So in order to getting the food, or in order when someone or people decided to consume a particular of the food, it is actually there is an interaction between the external and personal domains. Like, for example, the interaction between availability and accessibility, the presence of the food and the access, the distance of physical distance of the food. If the food was very available in one area, but if the distance of the people to access the food is far enough, maybe the people will be thinking about does the food will be consumed or not. So this is the basic explanation about the interaction between external and the personal domain. From the literature review that we gathered, so we creating the questionnaires. Here we use the pre-natal factor, socioeconomic, familial until the individual factor before become the criteria of our study. Meanwhile, from the framework, conceptual framework, we develop the external domain and personal domain of our study. And this is some of the interesting results of our study. We finding about the presence, the food vendor products properties. It's described as the presence of concentration as specific components. So this is, in our study, we use the description of the sugar concentration on the beverages, and then we found it that by the increased concentration of the beverage will be increased the risk of being overweight and obesity among children in Indramayu district. And it is because the explanation behind this finding is the increased sugar concentration will be increased exposure to the high sugar beverage among elementary school students in the Indramayu district, and somehow it will be children will be consumed more high sugar beverage. So the other study, the result of this study is the food affordability. We found this study found that for those children who are thinking that the sweet food cost is cheap, it will be increase their risk for being overweight or obesity compared 3 times higher compared to the other children that thinking the food is non-cheap. So the cheap food will be make food more attractive and it's affordable. So it will be creates children more frequently to cash and consumption for this food. And yeah, this is the potential intervention that we create to reduce risk factor of non-communicable disease in Indonesia, which is basically come from personal study. So actually, there are many potential interventions that can be conducted in order to reduce the risk factor. But I think it is very important to take priority in which intervention that we will conduct. So it can be gathered or it can be conducted through some evidence that we conduct before. And in order to deal with the non-communicable disease, actually the WHO has been provide us some regulation from 2004 until 2019, which is the strategy on the daily physical activity has been introduced from the 24, follow some additional interventions like promoting sugar tax, and also the community-based intervention, and the recent guidelines on the physical activity, sedentary behavior, and sleep behavior also provided by the WHO. And this is our study in 2020. In 2020. So this study found out about how the trends of adolescent smoking prevalence and empower achievement globally. So empower itself is a tool of measurements, which is provided by the WHO to assist each level country in order to deal with the risk factor of the non-communicable disease, especially for the smoking. Empower, M is stand for the monitoring the tobacco use. The P stand for the policy here. The O is overing for the people for quit from the tobacco use. The W is the warning, and then E is enhanced for ban from the tobacco through the advertising, and then R is the rating tax within the country. So in 91% country, through the ordinary less square model and spatial model, here we found it that this is actually between 1999 and 2018, there is a decreased prevalence of smoking among adolescents, which is for the male, it decreased minus 6.8, and for the male, it decreased about 6.4. So the result of our study using the ordinary square and spatial error model, we found it that among male, the warning it's somehow the warning somehow is will be increased. They contribute to the decreased prevalence of smoking among adolescents. Meanwhile, for the women, both for the ordinary square model and spatial error model, heartwarming is associated with the decreased prevalence globally. And this is some how we integrate our research into the initiative of the preventive or non-communicable disease in Indonesia, because in our study we found that the parents have less adequate about their perception among the nutritional status among children. So I think it is very crucial to enhance parental awareness regarding the children's nutritional status. And also, if we want to conduct or implemented the NCD release in Indonesia, we can targeting the urban and cluster area from our study. And also, I think increasing tax is also important because our study found that the more chips, beverage, and sweet food will be increase the risk for being overweight and obesity. And the last, we also guiding government to introduce a standardized food grading system. This is the food grading system that commonly happen in Singapore, which is it is become a national policy. I don't know, in Indonesia has not been introduced yet, but I don't know in the Thailand, but in Singapore, for every foods and beverages that produce, they have to check the grading system in the packages. Like in here, the grading system, it's come from A until D. So it is represent the sugars contents within the food of beverage. Like A is no sweet, and B is 1 until 5 gram per 100 milliliter. C is 5 until 10 gram per milliliter, and D is more than 10 gram per milliliter. So if this beverage grading C means it is between 5 until 10 grams per milliliter. So what is the good news in Indonesia? Even though there is a national policy that regulates about the food grading system, but in some food stores, or I found it, it is an initiative to introduce about the food grading system. Like it wasn't directly was print out in the beverage cans, but in the container, it's provide the information. For example, it is the groups of the food. Uh, the color is the orange, so it's the sugar concentration is between 6 until 12 grams per 100 milliliter. So I think it's a good point for Indonesia to further implement the national policy uh, to regulate about the production of the food and beverage in Indonesia. Thank you very much.
Okay, thanks. Thank you so much, Mrs. Sophie. It's wonderful presentations. Talk about the preventing obesity, yeah, in adolescents and in children. Okay, ladies and gentlemen, I'm sure that you all are ready to join a discuss with this second speaker. And we provide a chance to you all if you want to ask directly to Mrs. Sophie, or if you want to write your question on the chat box. Okay, we will give you for 3 questions first. Please mention your name. Okay, we have a question. Wait a moment. Yeah. Okay. Who will give a question for Mrs. Sophie? Please mention your name.
I have some question.
Okay. Please speak louder.
Okay, hello. I'm Vio from Indonesia. I would like to ask you a question about the material that has been presented. How to advise children to understand that not all delicious food is healthy. So that when children buy snack at school or at home, they can choose healthy ones. Thank you.
Okay, thank you, Fioli. Okay, maybe you can answer directly by Mrs. Sophie. Yeah, how to educate the children so they can choose which one is healthy food, and how about the communication maybe, please. Okay, we have second participant who will give a question. Maybe we will write the question. So we will collect 3 questions. Okay, please, Mr. Rudy, you can mention your question.
Thank you for your time. It's a very interesting result, yeah, and a very nice presentation. Its information is very clear for me, but I have a question. In Indramayu, children are very susceptible to sugar. Okay. Can you get it? Okay. The risk factor for children rich and consuming high sugar food and drinks are inseparable from the role of school and parents, I think. How can we collaborate to reduce this risk factor? Okay. And then the last question: how can we educate food and drink sellers in around school to avoid selling unhealthy food and drink to children? Okay, thank you.
Okay, thanks a lot, Mr. Rudy. It's a great question. Anybody who will give a question again?
I have a question. Is there a program that can be implemented in schools to monitor students' body mass index?
Okay, thank you, Intan. Okay, Mrs. Sophie, there are three person actually for the question. There are four questions. First, from Violin, talk about how to educate the children about good food, please.
Yes. Thank you very much for the questions. I think this question somehow is similar each other, so I will answer the questions together or directly. And then when I began study about the obesity and overweight in Indonesia, we are thinking about two options. The first option is community in a community area, and the second option in the school area. So based on the characteristic of Indonesia, or maybe Indramayu district, we found it that somehow the parents or children will be more respectfully if they are listening to the parents. Sorry, listening to the school except to the parents. So this is the reason why finally we want to start our study in the school setting area. So for the questions, for the first question from the violin, which is how we finally educate the children. So we can start from the school setting, because the reason why behind we start from the school setting, it is because the school area will be more acceptable for the children compared to their parents. So maybe we can create some programs together with the school in the school. Like in 2018, I ever promote or introduce the bocah petualangan bocah cilik Indramayu, or in English it's like the children's it's really hard to explain in English, but we introduce the physical activity among children start from the school setting area. So I think starting from the school, it's a very good point. And the others questions is about the roles of the parents and the school. In order to talking about the roles of the parents, I think it's a little bit complicated, because the result of our study found that the perception of the parents itself, we have some less appropriate, because many parents thinking that somehow the overweight children is a very normal and very cute. So I uh, I couldn't say that it is will be more acceptable if we will starting from the school area or school project area, and then after that, if the school was confirmed, we can getting hand by hand with the school in order to educate parents about the children's nutritional status. For the question about how we educate the street vendor about unhealthy food, I think it is a very challenging for us to educate food vendor about the healthy food, because somehow it will be it will be we have to deal with the issue of the economic status of the Indonesia society. So I'm worried that if we just provide the information about the unhealthy food, it will be also influence the income status of the food vendor. But actually, I think the most strategic approach that we can introduce is by providing the regulation. maybe together with the school, the headmaster of the school, I know from some school in Indonesia, they provide a regulation that there is restriction for the street vendor to sell the food around the school area. So I think this is one of the most strategic approach that we can use in order to control the sugar beverage around the school. And from the questions about is there any program to controlling the nutritional status in Indramayu and in Indonesia generally? Yes, there is a routine or a regular health checks up among elementary school conducted in elementary school in both in Indramayu district and in Indonesia. Is it clear for all the participants who asked questions?
Okay. Violin, Intan, Mr. Rudy, is it clear? Is it enough or any feedback from you? Enough.
It's very clear for me.
Okay, thanks a lot. Okay, we invite another participant who will give a question. Wait a moment, I will check on the chat book. Is it question already? Oh, yeah, not yet on the chat book. Okay, please, ladies and gentlemen, you can ask directly. Please mention your name and mention your question. Okay, Mrs. Sophie. While we waiting another question from the participant, I also interested with your topic. Talk about food ingredients. Okay, maybe we can aware from the packaging of the snack, but how if we want to consume food without packaging? How we can prevent or aware that it is excess of sugar or no? Thanks a lot.
Yeah, it's sorry. The question is if there is no information containing in the packaging, how the
Yes.
children realize it is sweet or not.
Yeah, like that.
So sadly, in our study also found that somehow the tolerance of the sugar tolerance among children the comparisons of the sugar tolerance between obesity and normal children is significantly different. What is this study described about? So in the same level of sugar concentration, the normal children will be perceived higher compared to the obesity or overweight children. For example, there is a 10 gram milliliter, there is 10 grams sugar concentrations per 100 milliliters. If we test to the normal children, they will perceive this sugar concentration at the level of 5. But if we test the same of concentration for the normal children, they will perceive this level of sugar concentrations is only 2 or 3. So it's statistically significant difference. So what we found is among overweight and obesity, there is problems with the sugar tolerance among their tones. So in order if we want to realizing the children, is it our sugar or not, it's a very big challenging because for children themselves, how they perceive the sugar concentrations is a very different between normal and obesity children. So what we can do is, but I think commonly in Indonesia, there is in almost all packages, there is information about the sugar concentration because mandatory, the government of Indonesia is have a regulation that every product in Indonesia, both in the food and beverage, must contain the nutrition information. So I think it is not hard in Indonesia to find it, the nutrition information or sugar information concentration in Indonesia.
Okay, thank you so much, Mrs. Sophie. It's so clear. Okay, please, anybody who want to give a question, we still have time to join the discussion. Yeah. Okay, and as you said before that, the excess sugar that consumed by the children, it can be minimized with the activity. Yeah, so actually in this era, I think children more interest to join an internet, make a game online. So it's so minimized of activity that can doing by the children. How to um, make a solution of this big problem? Maybe you have some experience. Can you share with us, please?
Okay, so maybe this is how I learned when I'm living in a Japan country. The children in the Japan is engaged more physical activity compared with the other country like in Indonesia. It is because there is a regulation in the Japan that the children have to walk uh, individually into the school area or elementary school. So by this regulation, of course, it will be increase the physical activity among the children. And recently, in the Japan country, also provide the regulation that they minimize the number of the screen times among children only 2 hours per day. I don't know how this strategy will be approached in the Japan. So maybe by using the technology, it is automatically the gadget or mobile or iPad in there. If there are maximum 2 hours, and then it will be cut directly. So this is uh, by I think in order to creating more physical activity in Indonesia, it is very challenging for us, and we need more multi-sectoral collaboration in order to deal with these problems. Not just simply we educate the children to do more physical activity. It is not simple as that, but we all have to conduct multi-sectoral collaboration from the policy, from the school, and from the parents itself. Thank you.
Okay, thank you, Mrs. Sophie. So, from your statement, I imagine maybe I have to buy bicycle as soon as possible. Maybe I will go to my college with a bicycle. It will give me more activity than I go by another transportation. Okay, we still have one question more for the participant. Who will give the question, please? Yeah, okay. While we waiting, Siriwan, are you still with us?
Yes, yes, yes.
Yeah. Okay, I'm sure you um have you heard about the question from several participants. Maybe I want to know about your opinion. Talk about obesity in
Yeah.
children. Uh, how the phenomena in Thailand. Please
Yes,
tell us.
I agree with Sophie. This problem is a big problem because it's right now we go to the digital era and the children have mobile phone or the iPad. So that I think the multi-sector would to do together for solve this problem, especially in Thailand. The obvious children have incident, and we have the research for this phenomenon. Use the game to have uh, uh, it seems like the to empower have the activity for the children to have activity to decrease the body weight or some action to do and for the interesting. I think this is very important issue that we put to solve the problem for the sustainable goal of us. And if we have and if we don't have the children who obese, so in the future we not have the patient with NCD. I think that just
Yeah.
it's difficult to do this problem is very difficult.
Yeah, I agree with you because maybe start from their family, yeah, how they make activity at home, and then how to organize or manage the activity at school, yeah, and maybe the regulation uh, from the government. Yeah.
Yes,
Okay.
yes, yes.
Uh-huh.
In our college, the student use the lift to instead to walk. Many student nurse don't like to walk. I think this is not okay for her in the future.
Yeah, I agree with you. Okay, we have a question from Laila Firdayanti. Hello,
Yes,
I'm
yes.
Laila Firdayanti from Indonesia. I have a question related to non-communicable disease, one of which is depression. Maybe risk of NCD is depression. What if child with depression has difficulty moving due to their low energy? This will automatically reduce their activity level and increase the risk of obesity. How can we as adults help our children prevent obesity due to depression? This maybe Siriwan and Sophie can give the answer of this question, both of you. Siriwan first, please.
Oh. I think that the important thing of adult is to uh I mean to change the mindset for to help the children, because if we love the children and she want to encourage them to grow, and I think the family, especially the parents, have to understand them. I mean that the nature of the children or the nature of the adolescent is different from the adult. So if the family if understand and the normal activity in the daily life is very important, that the family can be support. Especially the parent is the model. The first thing is, I think the first thing is start in the family with the parent as the role model for the children and the adolescent.
Yeah. Okay. Thanks, Siriwan. Yeah. Start from family like that. Yeah. Okay.
Yes.
And then, please, Sophie, can you explain your opinion about this question, please?
Yeah, I am very agreeable I think it is very crucial to start from the parents because based of the social learning careers that I provide before, that's how the children imitates the other behavior. It's through the process called uh, reproductions, and it is basically what children see, what children do. So maybe first we have to motivate the parents to motivate the children, and then the parents itself is have to promote the healthy lifestyle within this family. So the children will be see what the parents activity. So I think the children also will be initiated. Somehow, I think by conducting more physical activity, it's also very valuable to reduce the depressions among the children because by creating more energy through the physical activity, uh, psychologically, maybe it will be released some hormonal and also will be very good for the depression.
Okay, thank you, Sophie. Okay, we still wait for the last question maybe because I'm afraid there is still question will deliver by the participant. Please wait a moment.
Vivian, for the question, I agree with Sophie because for the PBRI model, the approach, I mean the principle 3E and 3S consists of food, emotion, and activity. If we use this principle in the family, I think it is the first step to solve the problem, and it can link to the emotion of the family, and it might be to decrease the incident of depression. And I think it's not only family, it means the environment, the school, and the policy or the economic in the families, just to solve together.
Sorry, I have some questions. Is it also applicable if I want to use that platform in order to educate children among obese and overweight obesity children in Indonesia? Can I also use that platform for overweight and obesity cases?
You asked me for the question that
I'm asking about your platform, the telenursing that you used recently in your university. You developed this platform for the diabetic mellitus, but I'm asking about is it possible also to use for the overweight and obesity that maybe can be implemented in Indonesia?
For the obesity, I think it's not okay because the mobile phone just stop there, not have activity. They just only use hand to move or to use. But the obesity children have to use activity, have to use it. So the game, I mean game that have emphasize they to have activity is meant to encourage them to have activity and to decrease the body weight. And it seems like the exercise, but that exercise have a game, something like that. So challenge them to have the winner or to have the reward. So they have the activity, and then they can control the diet or control the BMI of them. I think is okay for them, not the application.
Thank you.
Or maybe if you develop the game through the application, it's okay for the children or the adolescent. It's
yeah.
okay. Yeah, thank you.
Yeah, yes, I agree with you. It is the next project. Yeah.
Okay.
Yeah. Because we need some games. So the solution is not give an advice, but implement what we want to the point the children interest, because the children interest to the mobile phone, so we can integrated the game by the mobile phone. I
Yes,
get
yes,
your
yes.
point.
Yes, 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 yes.
Okay. By the way, maybe we will see before we start to deliver the certificate, we will show you about the video. Mrs. Sophie, are you? Ah, okay. Wait a moment. Please wait a moment. Okay, ladies and gentlemen, it is the end of our hello. Yeah, ladies and gentlemen, it is the end of our discussion, and then wait a moment. Aduh. Yeah. After we join these two presentation from two very inspiring speakers, once again we would like to thanks to Siriwan and to Sophie for the knowledge they have delivered to us. We hope that the positive things you have conveyed can be implemented in our institution. And ladies and gentlemen, the next event is deliver the certificate and the placard from Stikas Indramayu to the speakers, and it will be delivered by the chairman of Stikas Indramayu to Mr. Rianto. It's your time.
Okay, thank you, Ms. Wibin. Thank you so much, Dr. Siriwan and Sophie PhD, for that great presentation. We really appreciate your coming to speak with us. There is a placard to say thank you very much.
Yeah. Okay, thank you so much to Mr. Rianto as a chairman of Stikas Indramayu. Ladies and gentlemen, maybe I hope we can see you all again, not only by online but also offline lah, like that. Okay, thank you very much. I am as moderator, giving you big thanks for your attention, and I'm so sorry if there is any mistake when I lead this discussion. Okay, and now I will give this event back to Master of Ceremony. Thank you.
Thank you.
Thank you so much, Nurse Wiwin Nuraini MCAP. Ladies and gentlemen, that was an excellent season 1, professionally guided by Nurse Wiwin Nuraini MCAP. We sincerely appreciate her effort in making the season smooth and informative for all participants. We will now have a short break before season 2 begins. Please take this time to stretch, have a refreshment, or attend to your needs. The break will last for about 2 hours, and we will resume promptly afterwards. To all participants, please join the Zoom meeting for the season 2 at 1 p.m. Thank you very much.
See you again at 1 p.m. Thank you.
Yeah, thank you. See you at 1 p.m. Bye.
It's my honor to introduce the moderator for this season, Mr. Oksan Abila, who will guide us through the presentation and discussion, ensuring that everything runs smoothly. The times and screen are yours, Mr. Oksan.
Thanks to our MC for leading the program and making it run smoothly. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to everyone joining us from different countries. Welcome to Session 2 of the International Webinar with the theme, The Experience of Caring Non-Communicable Diseases Patient. My name is Oksan Abila and I will be your moderator today. It is a great honor for me to guide this session. Before we start, let me ask, can you hear my voice clearly?
Yes.
Good, thank you. How are you today? I hope everyone to stay healthy. Today, we are very lucky to have excellent student speakers from Indonesia and Thailand who will share their knowledge and experience. I encourage everyone to actively participate, ask questions, and enjoy the learning experience. We hope that this session will be informative, interactive, and helpful for our participants in understanding the role of multidisciplinary collaboration in addressing non-communicable disease. All right, let's begin our session. The first speaker, Ms. Delia Mahera and Ms. Intan Gita from Indonesia. Dear Ms. Delia and Ms. Intan, are you already with us on Zoom? Could you please turn on your camera or say hello to confirm your presence?
Yes, we are ready.
Wonderful, thank you. It's a great to see you. We are looking forward to your presentation later. The second speaker, Ms. Chanakan Inmol and Ms. Natalia Kongbot from Thailand. Dear Ms. Chanakan and Ms. Natalia, are you here with us on Zoom?
Yes.
Please greet the participants so we know you are ready.
Yes, we are ready.
Okay. Perfect. Thank you very much. We are happy to have you here with us today. The third speaker, Ms. Yulia Stuti and Ms. Violin Asri Zahrani. Dear Miss Suryastuti and Miss Violin, are you already on the Zoom screen? Could you kindly say hello to confirm your attendance?
Ya.
Halo.
Menyimpan telepon Anda sudah hilang.
Excellent, thank you. We are excited to listen to your upcoming presentation. The fourth speaker, Mr. Pakapol Supapak, Miss Sukanya Pomsawat, Miss Panpasa Kajaisri, and Miss Paunapang Muntong from Thailand. Dear Mr. Pakapol, Miss Sukanya, Miss Panpasa, and Miss Paunapang, are you all connected with us on Zoom? Please wave or say hello to let us know you are here.
Yes.
Great, thank you. It's a pleasure to have all of you with us today. The fifth speaker, Miss Ika Nur Aziza and Miss Siti Nurhaifa Sahara from Indonesia. Dear Miss Ika and Miss Siti, are you already present on Zoom? Could you greet the audience so we know you are ready?
Oh, we ready.
Wonderful, thank you very much. We are really looking forward to your presentation later. The six speakers, Miss Kanokwan Rotsawong, Miss Kanterayon Pimai, Miss Supatra Itaraksa, and Miss Chirapon Klepkeson from Thailand. Dear Miss Kanokwan, Miss Kantira, Miss Supatra, and Miss Chirapon, are you already with us on Zoom? Kindly say hello to participants. Know you are here.
Hello.
Oh, thank you. We are very happy to have you as our final speaker today. We are very excited to have all of them here today to share their knowledge and experience with us. Before we move to the presentation, let me explain some simple rules. Each speaker will have 25 minutes for the presentation. After the presentation, we will have 5 minutes for a short Q&A. Please keep your microphone mute if you are not speaking. If you want to ask a question, you can use the raise hand feature or type your question in the chat Zoom. Speakers are allowed to share their screen when presenting their material. Thank you for attention. Now let's start with our first topic. Our first presentation is Nursing Care at Mr. C with diagnosis of congestive heart failure in the Bougainville room of Bayu Asih Hospital by Miss Delia Mahera and Miss Intan Kita from Indonesia. Dear speakers, are you ready to start your presentation?
We are ready.
Okay, Miss Delia and Miss Intan, the time is yours. You have 25 minutes for presentation.
Thank you to the moderator for giving me the opportunity to present today. My name is Delia Mahera Putri from the Bachelor Nursing Program, Indramayu College of Health Science. In this occasion, I will present about nursing care at Mr. C with a diagnosis of congestive heart failure in the Bougainville room of Bayu Asih Hospital, Purwakarta Regency. Indonesia is the largest archipelagic country in the world, with a population more than 280 million people spread across 38 provinces. As the fourth most populous country in the world, Indonesia holds great potential for national development, particularly in the fields of education and health. One of the provinces with the largest population is West Java. Its strategic location adjacent to the capital city make West Java a region with a dynamic social, economic, and educational growth. One of the regency in West Java is Indramayu, a northern coastal area well known as a rice granary. In addition, Indramayu has also experienced significant progress in education, including health education. This is marked by the presence of the Indramayu College of Health Science, or STIKES Indramayu, which play an important role in producing professional and competitive health workers who are ready to meet the needs of society, particularly in the northern coastal region of West Java. Indramayu College of Health Science has sufficient to become a health education institution that produces professional, outstanding religious graduates who are able to compete globally by 2045. Based on the curriculum on the Indramayu Health Science of College Bachelor of Nursing, in order to achieve comprehensive student competencies in cognitive, affective, and psychomotor domains, the learning process is carried through clinical learning experiences. Clinical learning experiences has a credit load of 3 credits, consisting of 1 course, medical surgical nursing practice. And then this is the clinical learning experiences has been conducted for approximately 3 weeks, from January 6 to January 25, 2025. The hospital for clinical learning experiences is located at Bayu Asih Regional General Hospital in Purwakarta Regency. And then there are some of the rooms where we are providing nursing care, including annual room for internal medicines, adolescent room for surgery, and hematologist room, and last, bougainville room for heart and lungs, and other. Next, there are several competencies that we must achieve in clinical learning experiences, including first, assess the health status of clients. Second, analyze and interpret data accurately. Third, set priorities and formulate nursing problems and diagnosis appropriately. And fourth, identify nursing action goals, including deadlines for achieving results. 5, develop a nursing action plan. And 6, implement nursing action. 7, develop evaluation criteria. And lastly, establish and maintain attentive, therapeutic, and effective interpersonal relationship with clients. During our clinical learning experiences, there are several targets for action. Some action we carry out directly, like, for example, IV insertion, intravenous therapy, nebulization, oxygen therapy, and other. And then while others we only observe. For example, like suctioning, transfusion administration, acting, or upacting. And then here's the description of the case we took. A 51 years old man was admitted to Bougainville ward of Bayu Asih Regional General Hospital Purwakarta Regency with a medical diagnosis of congestive heart failure. At 6:42 p.m. on January 3rd, 2025, the patient was admitted to the Bougainville room with complaints of shortness of breath and coughing and edema in the lower extremities for further treatment for heart disease. And then during an assessment on January 6, 2025 at 9 p.m., the patient was found to be conscious with an A is 4, M is 6, and V is 5. Based on an interview with the patient, he reported a shortness of breath, feeling heavy when moving around, and still experiences shortness of breath while resting. The patient also reported while feeling weak, requiring assistance from family members for activities, being unable to care for themselves with activities limited to bed rest, and the extremities were warm to the touch with a grade 1 edema present. And then previous hospitalization. Previously, the patient had been hospitalized at Bayu Asih Regional General Hospital Purwakarta Regency for the same condition. The patient also reported smoking 2 packs of cigarettes per day and frequently drinking coffee. The patient has a history of hypertension. The patient reported having heart disease for the past 4 months. The patient said that no family members have the same condition. And then the patient elimination pattern while hospitalized includes soft stool, defecating, and no complaints regarding defecation. The patient's urination pattern is liquid consistency with urination lower than 5 times a day. Urine color is yellowish brown and urine volume is lower than 80-100 milliliter. The patients complain of pain during urination and only a small amount of urine is passed due to an enlarged condition. And then physical examination findings, the patient is weak, conscious with vital sign, blood pressure 102 per 80 in mAg, pulse 75 beats per minute, respiratory rate 33 breaths per minute, and temperature 36.3 Celsius. And then oxygen saturation 97%. The patient appears short of breath. Additional breath sounds from here are present. On percussion, there is dullness and no additional heart sounds are heard. During the physical examination of the head, there is short black hair, no wounds, no bleeding, no lumps, no tenderness, and no complaints. The eyes appear symmetrical with no discharge, no bleeding, no eye swelling, no eyelid, no lumps, and no complaint. This is about other physical examination. There is normal. Next. And then this is a treatment that patient have. First, IV infusion of 500 cc NaCl, 200 milligram NaC via IV, and then 1 times 80 milligram aspirate orally, 1 gram ceftriaxone via IV, carbiaton 100 milligram orally, 2 times 20 gram furosemide via IV, and then cobdiflon 1 times 1 orally. And then azithromycin 1 times 1500 gram via IV, and then dobutamine 250 milligram via IV. And then this is data analysis for the first nursing problem. First, subjective data. The patient says he is unable to walk, and then the patient says that before being admitted to the hospital, he needed a help from his family to perform like activities. And then for objective data, first, activities assisted by family. Blood pressure 102 per 80 mmHg, and then pulse 75 beats per minute, and for respiratory rate 33 breaths per minute. And then the patient appears of short breaths. For 6 tachypnea, and lastly, oxygen saturation is 97%. And then this is etiology. First, congestive heart failure, and then left ventricular pump failure, decreased blood supply to the heart, anaerobic metabolism, metabolic acidosis, and lactic acid buildup, decreased ATP, fatigue, and activity intolerance. So for the nurse's problem is activity intolerance. For data analysis 2, first is the patient reports shortness of breath and coughing. And then for the objective data, there is grade 1 edema in the lower extremities and pulse 75 breaths per minute, respiratory rate 33 breaths per minute, and appears tired. For etiology is exercise, systolic load, increased preload, increased cardiac load, congestive heart failure, and then decreased cardiac output. So the nurse problem is decreased cardiac output. For the third Data analysis is the patient complaints of shortness of breath and coughing. The patient says that he coughed in productive. Objective data is nebulizer attached, respiratory rate 33 beats per minute, tachypnea, and oxygen saturation is 97%. For etiology is left ventricular failure, backward failure, increased LVED, and increased pulmonary venous pressure, increased pulmonary capillary pressure, and then pulmonary edema, secretion build-up, and ineffective airway clearance. So for the nerve problem, we are raising ineffective airway clearance. And then data analysis for the subjective data is the patient said that his naps were irregular and short. And second, the patient said that he often woke up feeling short of breath. And then for the objective data, the patient appeared weak. For etiology is decreased cardiac output, increased preload, pulmonary congestion and edema, dyspnea, cough, and sleep pattern disturbance. So for nurse problem is sleep pattern disturbance. This is the last data analysis. For subjective data is the patient claims to be unaware of his illness. And second, the patient claims to be frequently consume fried foods and smoke cigarettes. For the objective data, the patients appeared confused when asked questions. For the etiology, smoking and eating fried foods, inappropriate behavior, problems arise at not knowing what to do, and lack of exposure to information, and then become knowledge deficit. Okay, that's the material I can convey. Next, I will give to my partner, Intan Gita Syaharani. Next, I am Intan Gita Syaharani. And I will continue the presentation with the intervention and evaluation that have been carried out in this case. Okay, we will start with the nursing diagnosis priorities. In this case, there are several nursing diagnoses. Firstly, decreased cardiac output due to change in preload and afterload as evidenced by the patient complaining of shortness of breath. Grade 1 edema, respiratory rate 33 per minute and appearing tired. Secondly, ineffective airway clearance due to occurrence object in the airway as evidenced by the patient complaining of shortness of breath, coughing, nebulizer in place, respiratory rate 33 breaths per minute, and third is activity intolerance due to imbalance between oxygen supply and demand, as evidenced by the patient reporting weakness, requiring family assistance for activities on a defibrillator respiratory rate 33 breaths per minute. Fourth is sleeping pattern disturbance due to decreased cardiac output as evidenced by waking up due to shortness of breath. And finally, fifth, knowledge deficit due to lack of exposure to information as evidenced by not knowing anything about his illness. Next is nursing intervention. For diagnosis, first we do observation, such as identify primary signs and symptoms of decreased cardiac output. Then monitor blood pressure, 12-lead electrocardiogram, monitor cardiac laboratory values, and monitor oxygen saturation. For therapeutic, position the patient in a semi-fowler or fowler position with the legs down or in a comfortable position. For education,
We do encourage gradual physical activity and collaboration. We collaborate on the administration of antiarrhythmic drug. Nursing intervention diagnosis. Second is observation, monitor breathing patterns, and monitor additional breathing sounds like gargling, wheezing, or diarrhea. For therapeutic, perform chest physiotherapy and education, teach effective coughing technique. For collaboration, we collaborate on the administration of bronchodilator, expectorant, and mucolytic. Nursing intervention third, observation, identify bodily function that cause fatigue. Therapeutic, we facilitate sitting on the side of the bed. Education, we recommend bed rest. And for collaboration, collaborate with a nutritionist on ways to increase food intake. Nursing intervention fourth, observation, identify sleep activity patterns, and identify factors that interfere with sleep. Therapeutic, facilitate stress relief before bedtime and adjust medication schedule and or intervention to support the sleep-wake cycle. For education, we explain the importance of adequate sleep during illness and teach factors contributing to sleep pattern disturbance. In this diagnosis, there is no collaborative action. For lastly, nursing intervention with observation, identify readiness and ability to retrieve information, and identify factors that can increase and decrease motivation for clean and healthy living behavior. Therapeutic, provide health materials and education, and for education, we explain risk factors that can affect health and teach clean and healthy living behavior. And in this diagnosis, there is no collaborative action. Next is evaluation. After receiving nursing care for 3 times 24 hours, the patient was discharged on January 8, 2025. Evaluation, diagnosis first, subjective. The patient says he still feels weak when doing light activities. Objective, there is grade 1 edema and the patient activities are assessed by family members. For assessment, the problem has not been resolved. For planning, intervention is continue. Implementation, recommend gradual physical activity. And for evaluation, subject, the patient report having performed activities gradually and not feeling short of breath. Objective, the patient does not appear short of breath. Respiratory rate 21 breaths per minute. Assessment, the issue has not been resolved, and for planning, intervention discontinue. Evaluation 2, subjective. The patient says they still feel weak. Objective, the patient appears to be lying in bed. Assessment, the problem has not been resolved. Planning, intervention is continue. Implementation, perform chest physiotherapy, teach effective coughing techniques, and administer bronchodilator. For evaluation, subjective, the patient reports that shortness of breath has decreased and coughing has decreased. Objective, the patient no longer appears to be coughing, no secretion present, and respiratory rate 21 beats per minute. For assessment, the issue has been resolved, and for planning, intervention discontinued. Evaluation 3, Subjective, the patient reports still feeling short of breath and still experiencing productive coughing. Objective, wheezing sounds are heard and secretion are present. For assessment, the problem has not been resolved. For planning, intervention is continue. Implementation facilitates sitting up in bed and perform passive and active range of motion exercise. Evaluation, the patient reports no longer feeling tired. For objective, the patient appears able to sit beside in the bed. The assessment issue has been resolved. And for planning, intervention discontinued. Evaluation for subjective, the patient reports difficulty sleeping. Objective, the patient appears to have difficulty sleeping due to shortness of breath and coughing. For assessment, the problem has been resolved. For planning, intervention is continue. Implementation, identify factor interfering with sleep. Evaluation, subjective, the patient reports being able to sleep. Objective, the patient appears to be able to sleep a little, and the patient appears to be able to sleep at night. For assessment, the issue has been resolved, and for the planning, intervention is continued. For person 5. Subjective. The patient says he already knows about his illness. Objective. The patient appears to be listening attentively to the explanation given. Assessment. The problem has been resolved. Planning intervention is continued. Implementation. There is no implementation. For evaluation. Subjective, the patient said that they still remember the explanation about their illness. For objective, the patient seems to understand his illness. Assessment, the issue has been resolved. And for the planning, intervention discontinued. Okay, that's all our presentation on the congestive heart failure case. We apologize for any limitation. And now I will hand the session back to the moderator. Thank you.
Thank you very much for your nice and clear presentation, Miss Delia and Miss Intan. Wow, that was really informative. I especially like how you explained the nursing care for a congestive heart failure patient step by step. I'm sure everyone has learned a lot from your presentation. May I ask, how do you feel after presenting your material in this international seminar?
Presenting the material. Of course, I definitely happy and proud to have had the opportunity to present my experiences from the clinical learning experiences. As a prospective nurse, this will serve as valuable as preparation for my future work. I hope that my presentation can help to increase everyone's knowledge, and I hope that it will be useful for the public.
Thank you for sharing your thoughts, Miss Delia and Miss Intan. Now we will open the floor for 5 minutes of Q&A. Participant, please feel free to ask your question, raise hand or chat in the Zoom chat. Okay, we have one question from Rifanda Yulia Hidayat. The question is, how important do you think clinical learning experience is for nursing students? Miss Delia and Miss Intan, can you answer now?
Clinical learning experiences is very important and absolutely necessary for nursing students. As I said before, for me personally, clinical learning experiences will serve as valuable preparation for my future work. In essence, clinical learning experiences is the bridge between theory and practice. Why is so important? Because first, to applying theory applies to directly practice what is learned in class and industry labs. And then second, to developing clinical reasoning, like sharpening the ability to assess patients, prioritize actions, and make decisions in real-world situations. And then for developing soft skills, building therapeutic communication with patient, collaborating with medical teams, and professionalism. And last but not least, for building confidence. It successfully completed tasks reduces awkwardness and prepares students mentally to become work-ready nurses. In short, clinical learning experiences is a nursing student will not be ready to face the challenges of the real world. That's all my answer. Hope it helps.
Okay, thank you very much, Miss Delia and Miss Intan for your answer. Okay, next, I will waiting for next question. If you have question, please raise your hand or chat in the chat soon.
I have a question.
Okay, please say your name and what a question.
I'm Amelia from Indramayu. I have a question for Miss Delia and Miss Intan. What is the most effective primary preventive strategy to reduce the risk of congestive heart failure? Thank you.
Okay, Miss Delia and Miss Intan, can you answer question from Amelia?
Okay, I will answer Amel's question regarding how to prevent congestive heart failure effectively. Firstly, maintain a healthy lifestyle. Secondly, we can control key modifiable risk factor like manage high blood pressure, high cholesterol, and diabetes. Maybe this is sufficient for the first step in preventing congestive heart failure. I think that's enough.
Okay, thank you, Miss Intan, for your answer. Because we should time effectively. We should move on the. Oh, okay. Wait. We can move to second topic. The second topic is multidisciplinary collaboration in primary care for nursing by Miss Chanakan Inmol and Miss Nachalia Kongbot from Thailand. Dear speakers, are you ready to start your presentation? Okay, Miss Chanakan Inmol and Miss Nachalia Kongbot, are you ready for presentation?
Okay. Good afternoon, repeat teacher, and all my fellow classmates.
I'm today delighted to be here with you this afternoon. My name is Namsli. I am first year nursing student from Boromarajonani College of Nursing, Saraburi. Today, I have the honor to present on the topic of enhancing primary care in Thailand through multidisciplinary collaboration in nursing. Here is the outline of my presentation. Next slide. First, I will talk about the concept of primary care. Next, I will explain the role of nursing in primary care. Then, I will discuss multidisciplinary collaboration in primary care. Finally, I will present a case example, the challenges we face, and my conclusion. Next slide. First, let's understand what primary healthcare means. According to WHO, primary healthcare primary healthcare refers to health services that are easily accessible to the public, affordable, and provide holistic care. It includes health promotion, disease prevention, treatment, and rehabilitation. Next slide. In Thailand, primary healthcare serves as the first point of contact for people when they have health problems. This helps make healthcare services closer to the community and more easily accessible. This image shows an example of primary care hospital in Thailand. I would now like to invite Nacharya to continue the presentation.
Thank you, Nancy. My name is Nacharya. Okay, I'm proud to present you about 5 key principles of parental care, including it is the first contact. Family care is the first point of entry for patient. Second, continuity. They follow patient throughout their life. Third, comprehensiveness. Covering health promotion, disease prevention, treatment, rehabilitation, and palliative care. Fourth, coordination. Linking patients with other health service when necessary. Finally, person centered, focusing on patient needs and implement them in their own care. Next slide. Next, I will talk about nurses' role. Nurses play a central role in all of these principles. For example, in health promotion, nurses organize vaccination campaign and health education. And in chronic disease management, they monitor patients with diabetes and hypertension. In mental and child health, they provide internal care, safe delivery support, and breastfeeding counseling. So I'll pass it to Supata to continue.
Thank you, Nacharya. Good afternoon, everyone. My name is Supata, and I will talk about multidisciplinary collaboration. Primary care is not the repository of one profession alone. In Thailand, the team includes doctors for diagnosis and treatment, nursing for continuous patient care, and education pharmacy for national drug use, public health official for prevention and health campaign, village health visitation for home visit, and community engagement. Next slide. Collaboration brings many benefits. Patient research, holistic care, research, thematic, village, health outcome improved, efficiently for people with community based community with tongue in the health system. For nursing, this community relation mean they are not working alone but are part of the kingdom report recently. Next, next, Jirapon.
Thank you, Supatan. My name is Jirapon, and I will provide a case example and highlight some challenges. Let I consider a case of a 58 years old man with diabetes and hypertension. The nurse monitor his blood sugar and blood pressure while the doctor prescribes medication. The nurse then administers the medication and provide the education on how to manage his condition at home. This collaborative approach ensures that both monitoring and treatment were arrive for the patient best outcome. The pharmacist ensures safe drug use and public health officers arrange a local exercise program. Village health volunteers visited him at home to provide ongoing support. After 6 months, his condition improved significantly. As a result, his blood sugar level and blood pressure returned to a healthy level. He was able to reduce his reliance on medication and live a more active lifestyle. Next. However, collaboration is not without challenges. We face communication gap, shortage of staff, and overlapping load. The solution include care law, definition, interprofessional training, and digital health technology to share information effectively. In conclusion, multidisciplinary collaboration in primary care is essential for nurses in Thailand. It improves patient outcome, builds stronger community, and support sustainable healthcare. Thank you for your attention. We are happy to take questions. Thank you.
Okay, thank you for the great explanation, Miss Chirapon Pepkesol, Miss Supatra Itaraksa, Miss for your presentation. It's amazing to see how teamwork in nursing can make patient care more effective. I think participants now have a clear idea about multidisciplinary collaboration in primary care. Okay, may I ask something, Miss Chanakan, Miss Chanalia, or Miss Chirapon? How do you feel after presenting your material in international seminar? Miss Chirapon, can you hear me?
Okay.
Yes. How do you feel after presenting your material in international seminar?
Sorry Kak, apa?
Okay. Miss Chirapon, can you hear me?
Yes Kak.
Okay. How do you feel after presenting your material in this international seminar?
How do you feel after you present
Yes.
how do you feel after you present this during in the seminar?
So nervous or so happy?
How do you feel when you finish the presentation in this seminar? Is it okay or not? It is great and great a pleasure to present in the seminar, something like that. You can answer the host for the question, please.
I'm so exciting.
Okay. Are you nervous? Okay, Miss.
Yes.
Okay. Thank you for sharing your talk. Now we will open the floor for 5 minutes for Q&A. Well, for participants, please ask your question in the chat Zoom or raise your hand feature.
May I ask some question? From Thailand and Indonesia have different for the multidisciplinary care team. From the presentation of the first group, what do you think? In Thailand it easy or difficult to work with the multisectoral between the multidisciplinary care team?
Okay. From Thailand, are you can answer the question from Dr. Siriwan? Okay, Miss Jidapol, can you catch the point of the question from Dr. Siriwan?
That is easy to do because we have a volunteer or assessment.
Okay, because in Thailand we have health volunteer to do, and for the multidisciplinary care team in Thailand is my simple to do with work together. Do you know that is the key success factor in Thai healthcare system, because we have healthcare volunteer for the multidisciplinary care team to work together. Thank you so much for your question.
Okay, I think that's enough. Thank you for Dr. Siriwan from your feedback. Okay, participant, any more for question to Miss Chirapon and friend?
I have a question.
Okay, please say your name and what is your question?
Hello, my name is Delia Maharaputri from Indonesia. This is what I want to ask is what are the obstacles to providing health promotion in Thailand?
Okay, thank you to Miss Delia for your answer. Okay, for your question, I'm sorry.
But for the question, repeat again.
Yes.
Again, please.
Yes.
Sometimes they don't get and they don't understand the question. Would you please to say slowly?
Okay, to Miss Delia, please repeat the question.
What are the obstacles to providing health promotion in Thailand? Like difficultness or something?
What do you think, the student? What about the what about the again, please?
But the obstacles.
The modulator, can you translate, please?
Okay, Miss Delia, please repeat again your question, your answer.
Maybe you can write in the chat box.
Yes.
For more understand from your question. Thank you. And the student can answer the question.
I will write in the chat session.
Can student nurse answer the question, please? What is the purpose of providing health promotion in Thailand? What do you think about this question? Who can answer? You can answer.
Yes.
Just not only the presenter. In Thailand, many students from Thailand, you can answer, please.
Okay. Okay, Miss Chirapon and friend, can you answer question from in the chat books? The question is, what are the obstacles to providing health promotion in Thailand?
I think the purpose of providing health promotion in Thailand is a first contact with a community in Thailand.
Okay, thank you. Miss Delia, is that enough? Or you can say again?
Yes, thank you for the answer.
Okay, thank you. Thank you for Miss Chirapon for your answer. Okay, participant, are you can ask question again? Okay, because not question for participants to effectively time, we will move to the third topic. Before that, I'm say to thank you for everyone for your vacation, and I say thank you to our speaker for their answer. Okay, let's next to the third topic. The third topic is treatment for breast cancer patients, presented by Miss Suryastuti and Miss Violin Asri Zahrani from Indonesia. Dear speakers, are you ready to start your presentation?
Ready.
Okay, Miss Suryastuti and Miss Violin Asri Zahrani, the time is yours.
Thank you for the opportunities. Hello. Hello, I'm Violin. I'm a midwifery student at Sekolah Indramayu. Good afternoon, everyone. I hope we all happy. I will explain several things about the basics of non-communicable disease. My title is Caring with Empathy, Experience of Caring for Patients with Non-Communicable Disease. Okay, the first, I want to explain introductions. Non-communicable disease are chronic diseases that are not transmitted from person to person, last a long time, and generally develop slowly. Heart disease, cancer, diabetes, mellitus, asthma, chronic kidney disease, mental disorder, and addictions. Ladies and gentlemen, patients with non-communicable disease need not only medical treatment, but also emotional support. Ladies and gentlemen, the next is data on non-communicable. The first data from World Health Sciences 2024. 74% of global deaths are caused by non-communicable disease. And the second data from Ministry of Health. In Indonesia, non-communicable disease contribute to approximately 70% of death. The most common diseases include hypertension, diabetes, cancer, and heart disease. Ladies and gentlemen, here we also discuss the psychological impact on people suffering from non-communicable disease. The first is feelings of anxiety, depressions, and uncertainties about the future. Second, feelings of guilt and fear of being a burden on the family. The third, loss of motivations to undergo long-term treatment. And the last is drastic lifestyle change that affects self-confidence. And then next is why empathy is important in caring for non-infectious patients. Because building a relationship of trust between healthcare professionals and patients. Second, helping patients feel heard and valued. And last is supporting patient adherence to medical therapy. And the next is next are several ways to show empathy when we are faced with pain. The first is psychological burden on patient and families. Second, stigma or lack of public understanding of non-communicable disease. And last is limit time for health workers to provide counseling. And then this is strategic of empathy for patient communicable. The first is use active and caring with therapeutic communications. And then demonstrate patience, understanding, and non-judgmental attitudes. And then provide consistent emotional support. And last is involve the family in the care process. And then the next and last, that is my experience relative to patients. My experience is listen attentively. When a pregnant woman with diabetes shares her concern about her blood, sugar level, and health of her baby, the midwife does not interrupt, look the mother in the eye, and respond using reassuring language. This demonstrates that the mother feeling are valued and affirming. Next, I will hand over this material to my colleagues. Please go ahead to Sister Suliastuti. Thank you, Violin. Okay, dear audience, let me introduce myself. I am Surya Suti from Indonesia as a midwifery student. In here, I continue to present material from Violin. I will explain one of the non-communicable disease, namely breast cancer. Okay, I will start this presentation with the title Treatment for Breast Cancer Patient. What is cancer? A group of diseases that are not caused by infection with microorganisms, for example, bacterial, virus, fungi, and parasite, and are not transmitted between humans. And next slide. Why breast cancer considered a non-communicable disease? Because it is not infection disease. It is conjunctions and is more influenced by metabolic, genetic, and behavior risk factors. The latest data in Indonesia, based on the Ministry of Health, show science rate of 41.1 per 100% population and death rate of 70 per 100,000 population. And next slide. Basic factor. The first, genetic. Genetic can be the parent, sibling, and the other family. The second, lifestyle. For example, obesity, consumption alcohol, smoking, and the other lifestyle. In the third is more age 50 years. And the last is hormonal. For example, use of birth control pills. These are some examples of the cause of breast cancer. And the next slide is symptoms, which can be caused by breast cancer. The first lump is the breast or armpit. The second, change in the shape or skin the breast cancer orange peel. The third is nipple discard color yellow or bloody. The fourth, pain discomfort. And the last, breast surface feels pulled or dimpling. The next we'll discuss about how to diagnose. The first, be aware. Be aware or sadari can be done independently at home. Second, clinical examination. Examination by healthy work. And last, third, mammograph. This is low dose X-ray technologies tools. And the last slide, how to breast cancer prevention. Primary, avoiding risk factor and adopting health lifestyle. Secondary, early detection such as breast self-exam and mammograph. The last, prevention, tertiary, managing extension, disease, and complication to prevent worsening. Okay, maybe that all presentation I can deliver. I apologize if there are any errors in the presentation.
I had it back to Master of Ceremony. Thank you.
Okay. Thank you very much for the informative presentation, Miss Suti and Miss Violin. I really appreciated the clear example you gave about breast cancer treatment. It makes such a difference to see practical case explained so clearly. Okay, Miss Suti and Miss Violin, how do you feel after presenting your material in this international seminar?
Nervous, but so far so good.
Okay,
Me too.
thank you, Miss Suti and Miss Violin for your sharing your talk. Now we will open the floor for 5 minutes of Q&A. Participant, please raise your hand or write in the chat box. Okay, we have some question from participant.
I have a question.
Yes. Please say your name and what your question to the narasumber, to the presenter.
Okay, I'm Eka from Indonesia. I have some question to Violin. Violin, what is your experience of caring for non-infectious patients with empathy?
Okay, thank you, Eka Nursabitri, for your question. Miss Violin and Miss Suresuti, can you answer question from Eka Nursabitri now?
Okay. I want to answer the question. Thank you for your question. It's a great one. Many healthcare professionals feel closer to their patients, understanding their conditions not only physically but also emotionally. For example, a midwife who assists a pregnant woman with gestational diabetes found that empathy made the patient feel calmer, more willing to ask questions, and more enthusiastic about treatment. That's my answer. Thank you.
Okay, thank you, Miss Violin, for your answer. Okay, Miss Eka Nursabitri, is that enough for your answer?
Okay, thanks for the answers, Vio.
Okay. We have one question again from Reni Fitriani. Regarding the previous discussion, it's important to note that one way to determine a diagnosis is through a sadari. The question is, when is the best time to doing that? Okay, Miss Surestuti and Miss Violin, can you answer a question from Reni Fitriani now?
Thank you for question, Reni. Allow me to answer your question. The most effective time to perform Be Aware or Sadari is 7 until 10 days after the first day of menstruation, when the birth and most relaxed and less sensitive due to hormonal functional. Thank you.
Okay, thank you very much, Miss Surestuti, for answer. Okay, Miss Reni, is that enough? Okay, thank you. Okay, thank you very much to everyone for your question, and thank you to our speaker for the answer. And we will move to the next topic, The topic is multidisciplinary collaboration in primary care for midwifery by Mr. Pakapol Supapak, Miss Sukanya Pomsawat, Miss Panpasa Kajaisri, and Miss Praunapang Muntong. Dear speakers, are you ready to start your presentation?
Yes.
Okay. The time is 25 minutes. The time is yours.
Good afternoon, everyone. My name is Pakapon, and I will start our presentation on enhancing primary care in Thailand through multidisciplinary collaboration in midwifery. Primary care is the foundation of Thailand health system, and midwifery services are crucial for promoting maternal and child health. However, midwife cannot work alone. Collaboration with doctor, nurse, pharmacist, nutritionist, and public health officials ensure that mother and newborn receive comprehensive care. Today, my team, I will share about the role of midwife, the importance of multidisciplinary collaboration, and real example from Thai community.
Thank you, Pakapon. My name is Sukanya. Today I will talk about the role of Thai nurse in safe childbirth assistance. Childbirth is a very important moment for both the mother and baby. Safe carry during and increases survival chances. Midwife important role in providing services, including antenatal care. Nurse provide antenatal check-up, give nutrition advice, and teach mother how to prepare for delivery. During childbirth, midwife monitor labor, ensure safety, and assist in childbirth with proper technique. Postnatal care, nurse care for the mother after birth, prevent complications and promote breastfeeding. Thai nurses are closely connected to community, reaching pregnant women even in rural areas. Next. Besides these services, midwives also have additional roles, including health education, counseling, and early detection of pregnancy-related complications. Next. To give you a clearer picture, let's see an example. Antenatal care. Monitor blood pressure, check fetal growth, screen folic, right, preeclampsia, or gestational diabetes, and educate on nutrition, mental health, and newborn care. Therefore, the role of Thai nurse in safe childbirth assistance is not only saving lives, but also building confidence for mother and family. Thank you. Thank you for listening. I will now hand over to Panpasa for the next part.
Thank you, Sukanya. Hello, everyone. My name is Panpasa. Today, I will talk about the importance of multidisciplinary collaboration the maternal and child health working together as a team improve care and outcome for mother and baby. Key collaboration expand obstetrician and doctor high risk referral. These professionals manage pregnant women with complication or high risk condition such or preeclampsia or diabetes. They also handle referral when advanced care is needed. Pediatrician and nurse newborn care. They take care of the baby after birth, monitor growth, give vaccination, and educate parents about newborn health. Nutritionist maternal diet counseling. Nutritionist guide mother on healthy eating during pregnancy and breastfeeding to ensure both mom and baby get the right nutrition. Public health and volunteer health promotion. They work in the community to promote healthy behavior, provide education on topics like breastfeeding, and vaccination, and connect families to health service. Next, I will share a case to show you the team collaborator. Next to Prang.
Yes, good afternoon. I'm Pang. I would like to share a practical case. At a healthcare center, a 28 years old pregnant woman come for her regular checkup at a local clinic. During the visit, the midwife found that her blood pressure was high. She quickly sent the woman to see the doctor. The doctor said it was early preeclampsia, which can be dangerous during pregnancy. The doctor started treatment right away. A nurse helped pregnant moms stay healthy. First, they check blood pressure and look for signs of danger. Then they give medicine to help mom feel better. Also, nurse teach mom how to eat healthy food and take care of team survival. Next, they work with doctor to make a safe plan for the baby to be born. After that, nurse still take care of the mom after the baby is born. They give support and check her health. The pharmacist gave her medicine that was safe for pregnancy. A nutritionist also gave her advice on healthy food to help control her blood pressure. Next slide. After she gave birth, the doctor and midwife continue to check on her and the baby. They also help her with breastfeeding and recovery. Because the healthcare team work together, both the mother and baby were healthy and safe. This here, this case, this case show how important teamwork is in taking care of patients. Thank you. We talk about midwife role in Thailand. If you have question, please ask. Please tell us if you want other topic.
Okay, thank you for your great presentation, Mr. Pakapol, Miss Sukanya, Miss Panpasa, and Miss Praunapa. I really like how you saw the importance of collaboration in midwifery care. It's inspiring to see the teamwork across different roles. Okay, Mr. Pakapol and friend, how do you feel after presenting your material in this international seminar? Can you say something about seminar?
Thanopang, I'm very excited.
Oh, okay. Uh, Thank you for sharing your thoughts. Okay, now we will open the floor for 5 minutes for Q&A session. Participant, please raise your hand or write on the chat box. Okay, well, we have some question. The first question from Jirapon. The question is, what are the main roles of Thai nurses during antenatal care? Before that, thank you for Jirapon for your question.
They
Okay, presenter,
provide,
you can answer. Oh, okay.
yeah, they provide neonatal checkup, give nutrition advice, and teach mother how to prepare to delivery. Yeah.
Oh, okay. Thank you for your answer. Ms. Jirapon, is that enough?
Okay.
Okay. The next question from Supatra. The question is, how do Thai midwife support women during childbirth?
They monitor labor, ensure safety, and assist in childbirth with pro proper technical.
Oh, okay. Thank you for your answer. Uh, Thank you everyone for your question, and thank you to our speaker for their answer. Okay, we will move to the next topic. The topic is field learning practice training for non-communicable disease by Miss Ika Nur Aziza and Miss Siti Nurhaifa Sahara from Indonesia. Dear speakers, are you ready to start your presentation? Okay. Are you ready, Miss Ika? Okay. I'm sorry, your voice While waiting presentation, preparing materials, I will say something about the narasumber. They are from public health.
Okay. Can you hear my voice, Oksan?
Yes, I hear your voice.
Well, sorry for the trouble. Okay.
Okay.
Thank you to the moderator for giving me this opportunity. Good afternoon, everyone. My name is Ikunur Aziza. Allow me to share our experience with you all about field learning practices, screening for the incidence of non-communicable disease, hypertension. What is hypertension? Hypertension or high blood pressure is when the pressure in your blood vessels is too high. It's about 150 per 90 mmHg or higher. It is common but can be serious if not treated. People with high blood pressure may not feel symptoms. The only way to know is to get your blood pressure checked. Hypertension is often called the silent killer because it usually has no noticeable symptoms. Many people can have high blood pressure for years without knowing it. The only way to detect it is to get your blood pressure measured regularly. Okay, this is the hypertension data in global. World Health Organization reported on hypertension in 2023 estimates that the number of hypertensive adults has nearly doubled globally over the past 3 decades, from 650 million in 1990 to 1.3 billion adults in 2019. The health impacts of the rising trend of high blood pressure translate into 10.8 million preventable deaths each year and 235 million years of life lost or living with disabilities. In Indonesia, based on the result of the 2023 Indonesian Health Survey or Survey Kesehatan Indonesia, the prevalence of hypertension based on measurement results in the population aged over 18 years of age of 34.4 has decreased compared to the results of the 2018 Riskesdas or Riset Kesehatan Dasar or 39.6. Okay. In West Java, according to the 2023 West Java Health Profile data, the prevalence of high blood pressure based on measurements reached 108.18%. The prevalence of high blood pressure in people aged 15 and over was 4.9%. In Indramayu, the estimated number of hypertensive patients over 15 years old reached 550,316 people, consisting of 273,949 male hypertension patients and 276,367 female hypertension patients. In 2023, the average blood pressure of the community in Balongan village is 122 mmHg, with the lowest blood pressure being 80 mmHg and highest is 270 mmHg. Okay, this is an overview of Balongan village. Balongan village of Balongan district is a village located in Indramayu Regency area. Geographically located, Balongan village is located on the beach. In general, the land located or found in Balongan village is used productively because it is fertile land, especially for pond and agricultural land. Although there is a small part that is not used by residents because it is a coastal area. Okay, these are two foods commonly consumed by Indramayu residents, namely nasi lengko and salted fish or ikan asin. Nasi lengko is a type of mixed rice containing cucumber, bean, sprouts, tofu, tempe, soy sauce, and crackers. Many people in Indramayu consume nasi lengko for breakfast. However, nasi lengko is high in sodium, which if consumed excessively can cause health problems, one of which is high blood pressure or hypertension. Salted fish or ikan asin also contains high level of sodium due to presence of salt, which is used as a preservative and flavoring. Okay, this is the education data. The pie chart illustrates the educational attainment of the community in Balongan Village, Balongan District, Indramayu Regency, as of 2023. The data shows a diverse range of educational backgrounds among the residents. First, a significant portion of the population, 27.4%, has graduated from high school or madrasah aliyah. The second largest group, 22.4%, has completed elementary school. Following that, 18.8% didn't finish elementary school. 18.4% of the community graduated from junior high school. A smaller group, 9.4%, has no formal schooling at all. 1.8% has graduated from university. And the smallest percentage, 1.7%, consists of those who have graduated from diploma. The next is the employment data. Here, the largest group at 27% is categorized as not working. This includes individuals who are unemployed, retired, or otherwise not in the workforce. The next largest group is self-employed or trader or service, and which makes up 26.7% of the population. This category represents people who work from themselves in various trades for services. Following that is the school category at 22.9%. This includes all students from elementary school to higher education. The remaining categories represent smaller portion of the population. Is provide employees account for 6.4%. The other category is 8%, and laborers make up for 0.7%. And the farmer are the smallest group at 2.4%. Okay, for the next material, I'll give it to Miss Haifa.
Okay, hello everyone. Saudi Cup. Okay, I am Haifa. I will next presentation. Hypertension case data. The distribution of the frequency of family member diagnosed with high blood. The slide present data on the frequency distribution of family member diagnosed with high blood pressure or hypertension in Balongan Village, Indramayu Regency in 2023. The data is shown in a bar chart with two categories. First, represent family member who were diagnosed with hypertension. This group makes up 9.7% with 226 individual. Second, represent family member who were not diagnosed with hypertension. This group makes up 90.3% with 2,097 individual. Okay, next slide. Okay, taking hypertension medication. Distribution of frequency of family member diagnosed with hypertension who take hypertension medication in Bolongan Village, Bolongan District, Indramayu Regency in 2023. Based on the data, it is known that 27% of those diagnosed with hypertension do not take high blood pressure medication. Okay, next slide. Okay, promotion and prevention. To overcome the occurrence of hypertension, do this. Okay, 1, eat more vegetable and fruits. 2, be more physical active. 3, lose weight if you're overweight or obese. 4, do strength building exercises 2 or more days each week. And 5, get at least 150 per week of moderate intensity aerobic activity. Okay, next slide. Nah, 1, eat too much salty food. Try to stay under 2 grams per day. Eat food high in saturated or trans fat. 3, smoke or use tobacco. And 4, drink too much alcohol. Nah, in Indonesia we have CERDIC. C for cek kesehatan berkala or regular health checks. E for nyahkan asap rokok, for eliminate cigarette smoke. R for rajin aktivitas fisik or regular and in physical activity. D for diet sehat dan seimbang, for healthy and balanced diet. I, istirahat yang cukup, for adequate rest can be achieved by sleeping 7 until 8 hours per day for adult. K for kelola stress or stress management. Nah, there is some documentation at the time my friend and I held the carried or health checks, namely hypertension check for hypertension servers in Indramayu. Nah, the following is a poster on the use of warm water immersion therapy to reduce high blood pressure. Benefit of warm water bath: improve blood circulation, help lower blood circulation, and relax muscles. Okay, thank you. That's all from us. I hand it back to the moderator.
Thank you very much for sharing your knowledge, Ms. Ika and Ms. Siti. Your presentation about field learning practice was very interesting. I'm sure everyone now understands the importance of early screening for non-communicable disease. Okay, Ms. Ika and Ms. Siti, how do you feel after presenting your material in international seminar?
Okay, I'm a winner first.
Oh, okay. You so nervous. Thank you. Thank you for sharing your thought. Okay, now we will open the floor for 5 minutes of Q&A. Participant, please raise your hand or write in the chat box. Okay, we have some questions. The first question from Panpasa Kajasri. The question is, how can public health nurses help prevent hypertension in community?
Okay, thank you, Alia, for the question. Let me answer. Because there has been research related to warm water immersion to lower blood pressure. Thank you.
I'm sorry, Miss Siti and Miss Ika. The first question from Panpasa Kajasri. How can public health nurses help prevent hypertension in the community? Can you answer now? Okay.
Okay, thank you to Ms. Panpasa Kajaisri from Thailand for the question. Let me answer it. For prevent hypertension in the community, we have uh, primary health care or puskesmas in Indonesia, and also as my partner said before about cerdik, uh, there is a prevention from Indonesia. Okay, that's all from me.
Okay, thank you, Miss Iko, for your answer. Miss Panpasa, is that enough? Okay.
Yes.
Yes. Uh, Thank you for Miss Iko for your answer. Okay, let's to the next question from Alia Nurfalinda. The question is, how is soaking in warm water related to lowering hypertension?
Okay, thank you, Alia, for the question. Let me answer. Because there has been research related to warm water immersion to lower blood pressure. It's also me. Thank you.
Okay, thank you, Miss Siti, for your answer. Okay, we have two question again from Nurlaila Sari. The question is, according to the material that has been presented, how do you carry out warm shock therapy to lower high blood pressure? Okay, Miss Ike.
Okay. Yeah. Okay, thank you for the question, Ms. Nurul Sari. Let me answer it. Okay. The first is sit with your legs dangling. Second, fill a container with hot water and half with cold water. And three, wash your feet if they look dirty. Four, cover the container with a cloth to maintain the temperature. And the last, check every 5 minutes if the water is slowly cooling. And add more hot water. Okay, that's to carry out to warm shock therapy to lower high pressure in community. Thank you.
Okay, thank you, Miss Ike, for your answer. The next question from Atini. The question is, what are the challenges during field learning practice activities? Okay, Siti, can you answer the question?
Okay, thank you, Miss Atini. Challenge ya. One of the challenge in practical field learning activities is language, because the Balongan village community still use
Okay. Thank you for your answer, Miss Siti, to effectively time effectively. Before that, I say thank you to everyone for your location and thank you to our speaker for their answer. Okay, let's next to the last topic. The last topic is multidisciplinary collaboration in primary care for public health by Miss Kanakwan Rotsawong, Miss Kantirayon Pimai, Miss Miss Kanoknat Sangjan, and Miss Chanakan Inmol from Thailand. Dear speaker, are you ready to start your presentation?
Yes, we are ready.
All right, time is yours.
Okay, good afternoon everyone. My name is Shanakan and I am proud to present topic strengthening public health in Thailand, implementing the prevention-based relationship integrative model to multidisciplinary collaboration in primary care. Our team has 4 members. The topic is about the PBR model concept. In part mention of the PBR model through a multidisciplinary approach, collaboration in primary care, case, example, and outcome. What is the PBR model? The PBR model is an approach developed by the Boromarajonani Institute in Thailand, integrating higher education mission, science, teaching, research, and academic service into the primary healthcare system. The main goal is to improve the quality of life for people in the community through a primary healthcare net.
My name is Kanokwan. This is a seven color topic ping pong model. We focus on the screening, surveillance, and prevention of both communicable and chronic non-communicable disease. One of the tools we use is the 7 color topic ping pong model. This slide shows BP and blood sugar level. While normal keep up healthy habit. Green at risk control your diet and be more active. Dark green will control you have a chronic disease, but is under control. Yellow needs monitoring. Orange dangerous high risk. You must be see a doctor regularly. Red critical very dangerous bad communication. We promote the 3R and 3E activity, which includes health promotion, disease prevention, treatment, and rehabilitation to reduce complications. We use community-based model which emphasize local wisdom, working across different disciplines, partner building and active participant from people in the community. This helps achieve better community well-being. We also encourage collaboration with other sectors such as religious organizations, schools, and other social institutions. Next.
Okay, I am Kanoknat and I will talk about how multidisciplinary collaboration works under the PBRI model in Thailand primary care system. For example, in managing non-communicable disease such as diabetes and hypertension, public health officer organize screening and health promotion program. Nurses provide counseling and follow-up care. Doctor diagnose and manage medical treatment. Pharmacists ensure safe and rational drug use. Community health volunteer support lifestyle change at the household level. By sharing responsibilities, each profession contribute its expertise. creating a comprehensive and sustainable approach to healthcare. Next.
Okay, my name is Kantila. Let me share a real-life example of PBRI model in action. In a rural community in Thailand, many residents were at risk of hypertension and obesity. A multidisciplinary team was formed. Doctors and nurses conduct regular checkup, and pharmacists manage medication. Public health officer organize exercise and healthy diet campaign, and community volunteer follow up with family at home. After 6 months, the community saw reduced blood pressure level, improved dietary habits, and greater participation in health activity. This case demonstrates that the PBRI model not only prevents disease, but also builds stronger relationship between healthcare team and the community. In conclusion, the PBRI model highlights the importance of prevention and relationship in public health. Through multidisciplinary collaboration, Thailand primary care system can effectively improve health outcomes and promote long-term well-being. Thank you for your attention. Do you have any question or any suggestion for our topic?
Okay, thank you very much for the valuable presentation, Miss Kanokwan, Miss Kantira, Miss Kanoknat Sangjan, and Miss Shanakan Inmol. I really appreciate how you highlighted the role of public health in multidisciplinary collaboration. It gives all of us a better understanding of teamwork in healthcare. Now, I want to ask something. How do you feel after presenting your material in this international seminar?
I'm so grateful to be here. Yes.
Okay. What about you, Miss Kanoknat? Are you nervous? Oh, okay. Thank you for sharing your thoughts. That's really inspiring. Okay, by the way, could you please tell us how do you say good afternoon in Thai language?
We say สวัสดี all the time.
Sawadi all the time. Is that correct?
It's just สวัสดี สวัสดีครับ
Sawadikap.
Yeah.
Okay, thank you. Thank you for your answer. Because this is make me to improve my language in Thailand language. Okay, now we will open the floor for 5 minutes of Q&A. Participant, please raise your hand or write in the chat Zoom. Okay, we have question from Sukanya Pomsawa. The question is, how can the community take part in the traffic ping pong models? Okay, Miss Kantira or Miss Kanoknat, can you answer now this question?
The community, I answer that. The community can join by the taking part in health screening, practicing healthy lifestyle, and working together with local organizations to promote well-being.
Okay, thank you, Miss Kantira, for your answer. Miss Sukanya Pomsawat, is that enough?
Yeah.
Okay, thank you for your question. Before that, I say thank you to everyone, to participant and speaker for your question and presentation. That was a very engaging Q&A session. Thank you to all our speakers for their clear and informative answer. I also want to thank all participants for your active participation and thoughtful question. Your enthusiasm made this session even more interesting and meaningful. Okay, the next agenda, we will have a photo section for all presenters. For all presenters, please activate your camera. Please, to all presenters to activate your camera. Okay, to all presenter, please activate your camera. I'm sorry, Miss Pan Pasaka Jaisri, can you activate your camera? Okay. Thank you for your attention. After photo section, the lead of organization commit will give it give the certificate by certificate for all participants. Certificate for all participants. For Miss Dewi Eka, the time is yours. Okay, Mrs. Dewi, are you hear my voice?
Yes. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Hello everyone.
Hello.
What incredible experience this webinar has been. We have heard so many great ideas and learned so much, all because of the hard work and talent of our student presenter. To our credible speaker from Indonesia and Thailand, a big thank you to each of you. Your presentation were fantastic and you truly shine on this international stage. We are immensely proud of your accomplishment. Their certificate are a small way for you to us to say thank you and to celebrate your success. Congratulations on job well done. Thank you.
Okay, thank you for Mrs. Devi for conveying information. We have just had 6 informative sessions covering topics from nursing care for cognitive heart failure patient, treatment for breast cancer, to multidisciplinary collaboration in primary care for nursing, midwifery, and public health, as well as field learning practice for screening non-communicable disease. This presentation has given us a comprehensive understanding of how teamwork and collaboration in healthcare can improve patient care and community health. I hope all participants have gained new knowledge and practical insight that you can apply in your own practice or studies. Once again, thank you to all our speakers from Indonesia and Thailand for your time, effort, and contribution to this international seminar. Your expertise has been truly inspiring.
Mana linknya nih?
On behalf of the committee, I would like to sincerely thank all speakers for their valuable time, effort, and insightful presentation. I also want to thank all participants for joining us today, actively listening and contributing to the discussion. We hope that the knowledge shared today will be useful and can inspire all of us in our professional practice. Let's continue to collaborate and learn from each other to improve healthcare together. I apologize if there were any mistakes from me as the moderator. Assalamualaikum warahmatullahi wabarakatuh. Sawadee. Thank you and see you in the next time. I return to the floor to the MC.
Thank you very much for Mr. Oksan Abdillah. Ladies and gentlemen, it concludes season 2 of our webinar. We sincerely thank Mr. Oksan Abdillah for skillfully guiding this session and all our speakers for their informative presentation. We also appreciate the active participation and engagement of all attendees, which made this session successful and meaningful. On behalf of the organizing committee, we hope you gained valuable knowledge and insight. Thank you for our speakers and our moderators who led the discussion. A gentle reminder that tomorrow, Friday, 29 August, we will have section 3 and 4 from International Webinar at 9 a.m. We're waiting for your participant tomorrow. Ladies and gentlemen, that's all for today. I'm Andini Sulistiani as the Master of Ceremony. Thank you very much and apologize profusely if any words that less pleasing to the audience here. Let us close the International Webinar 2025, the experience of caring non-communicable disease patient. Thank you and see you in the next time. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much สวัสดีค่ะ
สวัสดีค่ะ